We are live in 3, 2, 1. Sunisa, you can start.
Sure. Good evening, everyone, especially doctors for this forum. I invite everyone to be a part of an update on migraine webinar that we are going to have it with the distinguished speakers, the neurologists, the who's who in neurology division. I, Dr. Sunil Pandey, I represent CME Foundation of India, who invites you for the same. And a few words about my organization. It's a foundation that is encouraging the knowledge and updation for my doctor subscribers. We are into doing our own CMEs. We do association with medical colleges, including government. We do collaborative meetings with international, national organizations. And this is basically the benefit is to update the knowledge of our doctors who are members and subscribers of our organization. Let me welcome our course director for this event, the webinar, Professor Dr. Debashish Chowdhury. A few words about him. We'll be introducing the other neurologist speaker. Of course, he doesn't require an introduction, however, just a formality. Professor Dr. Debashish Chowdhury is actually a director professor and head of neurology in charge of headache clinic from GB Pant Hospital, New Delhi. His areas of interest include stroke and headache disorder. He has received a lot of awards as displayed. And the other perspective of him is he has directed a full-length Two Sisters on epilepsy theme and Ek Aur Talash, dealing with female feticide, for which he was awarded and highly acclaimed. Welcome, Professor Dr. Debashish. Platform is all yours.
Thank you. Thank you, Dr. Pandey. First of all, I thank your organization, the CME Foundation, and the partners for this conference, Health, and you who are actually providing an educational grant to conduct this meeting. And I think it's an important meeting because migraine is such a common condition that is being seen through and through, from the general physicians level to the specialist MDs, and then to the neurologist, and then the headache specialist. So I think it is very important because it is not only very common, but it entails a lot of issues regarding diagnosis, regarding regarding the management, and also, there are new horizons that are being created in the field of migraine research, which is basically a very exciting field. Just to percolate that knowledge and to help all of us to actually deal with this particular disorder, which is not very well recognized as a tremendous cause of disability. And in fact, if you know that according to the global burden study, migraine has been, actually assigned number 2 position. It's ranked number 2 in terms of years lost in disability, much ahead than all other neurological disorders taken together. So therefore, it becomes very, very important for us, and it makes sense to discuss the various aspects from diagnosis to management. And we have actually devised the program accordingly, and we have got very good speakers who are experts in this field. We'll be talking about it. And just to get the ball rolling, I will start with the basic topic for today, that is the migraine diagnosis. And I like to make it as easy as possible for all of you so that you have no difficulty in diagnosing migraine and then properly treating migraine disease. So I'm just going to start sharing my screen. Is my screen visible?
Yes, sir. Please continue.
Yes, sir.
Right. Okay, so just to kind of my disclosures, I work in GB Pant Institute of Postgraduate Medical Education and Research. We run a dedicated headache clinic for many number of years, and I have no disclosures pertaining to this particular presentation. I have conducted a lot of international studies on various drugs to be used in migraine, as well as I've conducted a lot of academic research in headache disorders, particularly in migraine. So first of all, we have to understand this, that the headache is not a disease. You cannot write over a prescription diagnosis as headache, although it's a very common symptom. About 99% of the world population suffer from at least one attack of headache during their lifetime. At least 50% of the world population suffer from at least one attack of headache in the last 1 year. And the maximum people in the world are disabled due to low back pain, followed by headache. Low back pain is number one, and headache, especially the migraine, is number two. It means that headaches are very common. Now, question comes that if headache is just a symptom, so how do you ascribe it to a particular disorder or a disease? And for that, there is a Bible that is available, and that is known as International Classification of Headache Disorders. And various versions have been produced since 1988. And currently what we are using is called the International Classification of Headache Disorders version 3, which was published in 2018. So this is the reference book for headache and headache classification. So based on this, there are three types of headaches groups overall that have been described. The two major chunks are basically the primary headaches, which, as you can see, constitute about 90 to 95% of the cases which you see in the clinics, and about 3 to 5% are constituted by the secondary headaches. And a small percentage are the neuralgias, the painful cranial neuropathies, 1 to 2%. Okay, so as you can see, the major chunk is the primary headaches. So what are the primary headaches? They are the headaches for which there is no discernible cranial pathology to account for in terms of anatomical or any other correctable underlying etiology. Okay, so they are generating from the brain, but nevertheless, if you do the imaging, you do the CT scan, you do the MRI, it doesn't yield to anything. You do all the biochemical investigations, it's normal. So there is no prima facie etiology to account for these headaches, and therefore they are labeled as primary headaches. And they are the commonest type of headaches seen in the general population. So this has to be remembered. Among the primary headaches, there are 4 groups which are described. Migraine, group 1, tension type headache, trigeminal autonomic cephalalgias, and other primary headache disorders. They are uncommon other primary headache disorders, right? But if you can see the second group, the part 2, the secondary headaches, you have a lot of subsections there related to trauma, injury, cranial or cervical vascular disorders, for example, cervical dissections, non-vascular intracranial disorders, substance abuse, infections, disorders of homeostasis, disorders of cranium, neck, eyes, ears, nose, sinuses, teeth, mouth, psychiatric disorders. So there are almost about 200 plus causes for this secondary headache. And then, of course, as I said, painful cranial neuropathies and other facial pains. The commonest one, of course, is, as you all know, trigeminal neuralgia. So you can see the dichotomy here. In one hand, you are saying that the primary headaches are commonest, constituting about 90 to 25%. On the other hand, you see the list, the maximum list is populated by secondary headaches. So the clinicians are always in a dilemma to know that the headache patient which is coming for consultation, is he having a primary headache or a secondary headache? And most of the primary headaches, the commonest type that comes to the clinic is migraine. So therefore, the distinction becomes that whether it is migraine or it's a secondary disorder. And that is important to understand. Of course, you all know there are a lot of red flag signs that can suggest that this is a secondary headache. For example, if the patient is having a telltale sign of a neurological sign like ptosis, diplopia, weakness, cerebellar signs, recurrent vomitings, right? Then you know that it is secondary headache. But sometimes they can be shrouded in mystery because the signs and symptoms may be very subtle. But more importantly, it is important to know that what are the features of these primary headache disorders. And therefore, you will be more surer. You'll be at ease to diagnose them as a primary headache and especially a migraine. That is the talk of today. So the three common primary headaches that will come to your clinic, and you need to make distinction. If you see about 10 patients in a particular outpatient clinic of headaches, you will see either of these three, and most commonly about 8 of them or 9 of them will be migraine. Migraine, tension type headache, and cluster headache. So let us first go that what is the definition of this disorder. Now, International Headache Classification not only lists the diagnostic criteria, but it gives a broad definition also. So migraine, how is it defined? It is an idiopathic recurring headache disorder manifesting in attacks lasting over 4 to 72 hours. The first thing is a long duration headache, right? Typical characteristics of headache are unilateral location, pulsating quality, moderate to severe intensity, aggravated by routine physical activity, and associated with nausea, photo, and phonophobia. So even if you don't know the criteria, but if you know this definition, there's a long-lasting headache with a throbbing unilateral quality, pulsatile quality, moderate to severe intensity, and aggravated by routine physical activity with systemic features like nausea, vomiting, photophobia, phonophobia, then you know that most likely you are dealing with migraine. Now let us see the criteria in detail. So you need to have 5 attacks, as I said, lasting for 4 to 72 hours, pulsatile quality, and the most important component that you should always ask, what do you do during your moderate to severe attacks of migraine? 98% of the patients will say, sir, we cannot work. We have to lie down. We have to take rest, because any movement, any continuation of the routine physical activity is going to aggravate migraine. Migraine is a highly motion sensitive disease. So this is a very crucial question that you should ask. And then, of course, you can have nausea, vomiting, or both. Most commonly, they will complain of nausea, vomiting occasionally, photophobia, and phonophobia. It is important to understand that what do you mean by photophobia? It's not aversion to bright light. It is aversion to normal light. It is aversion to normal sound. So that is very, very important to understand. And of course, ICSD says that you need to rule out by examination, history, and if needed, investigations, all other secondary causes of headache to label it as migraine. An astute clinician will know after seeing a lot of cases that, oh, well, I am dealing with a primary headache disorders if it follows these steps correctly. But I would say that consider migraine not as a single, entity just concerned with the headache part only. Migraine, in fact, is a syndrome. It's a continuum of symptoms. You have the premonitory phase, in which about 24 to 48 hours prior to the onset of the headache, the patients have mood changes, fatigue, cognitive changes, muscle pain, food craving. In about 25% of the patients, they may be having a fully reversible neurological change, which is known as aura. We'll come to that. And then the headache will start, a dull headache, sometimes with cranial autonomic symptoms like nasal congestion or redness in eyes, a slight watering, and then it intensifies, advanced headache, and usually starts unilaterally, side shifting, sometimes left, sometimes right, soon becoming holocranial, throbbing, nausea, phonophobia, osmophobia, and postdrome. Even if the headache is gone, patient is not well. There is fatigue, cognitive changes, and muscle pain. So if you take this history from the patient, because patient is going to tell you about the headache, but if you ask what happens before the headache and what happens after the headache, then your diagnosis will be more robust. It will have a solid foundation, because this kind of syndromic feature usually does not happen in other types of headache, like a tension type headache or a cluster headache. Cluster headache begins abruptly and ends abruptly, or and then the tension type headache does not have this kind of a premonitory phase, aura phase, or a postdrome phase, right? So therefore, it is very, very important to know and view migraine as a syndromic diagnosis. And of course, migraine patients will keep on complaining of other things as well, because migraine headache is just one part of the disorder. There is a sensory dysmodulation, there is a change in effect, mood fluctuations, there are cognitive dysfunctions. During the acute attack, the patient is not able to think properly, work properly. After the attack also, the patient may have cognitive dysfunctions. 70%, up to 70% of the patients of migraine will complain of neck pain. And therefore, many of them would actually go to an orthopod, for cervical spondylosis. And there are autonomic symptoms that might also be present. Therefore, at times it might become, even if it's a side-log, this one-sided headache or migraine with autonomic symptoms, it might become difficult to distinguish until and unless you know the syndromic diagnosis and you know the duration. Correct? We'll come to that. So why this diverse kind of symptomatology with just headache? Because for that, you need to know a little bit about the pathophysiology. Migraine brains are generally neurologically hyperexcitable. There are a lot of electrophysiological studies that have shown that these brains actually respond to sensory stimuli in a hyperexcitable manner. Why this is so? It's probably because of the genetic predisposition. There are a lot of genes that have been now actually being detected for migraine. Well, let's not go into detail about that. But this predisposition, and together with migraine triggers like stress, awakening, other physiological emotional changes, activate the nociceptive pathways, and then the hypothalamus gets activated. Now there is a clear-cut evidence that before the migraine headache starts, the hypothalamus gets activated and responsible for the premonitory phase of the headache. And then it actually, in some patients, develop a cortical spreading depression, resulting in aura. And then there is an inflammation of the meningeal vessels and the dura, and that triggers the changes in the trigeminovascular pathway, leading on to the pain signals being transmitted up through the brainstem to the various parts of the brain, as far as from the sensory cortex to the occipital cortex, to the insular cortex, to various parts of the brain, to account for this diverse symptomatology of migraine. Therefore, please remember, migraine is not a vascular disease. Migraine is a neurological disease and is generated by the brain. Vascular changes are epiphenomenon, secondary to the neuronal changes that are happening in the brain. So we can understand by this diagram that what are the symptoms of migraine and how they are generated. For example, throbbing pain, sensitization of peripheral trigeminovascular neurons, nausea, vomiting because of hypothalamus and hypothalamo-brainstem connections, photo and phonophobia, activation of visual and auditory cortical areas, aversion to motor activity and motion sensitivity, probably higher cortical areas, and so on. So, but importantly, as I said, neck pain is a very important component. So how does it connect? You can see that connection because you know that the trigeminal system is connected in the neck, the spinal nucleus and tract of trigeminal through C1, C2, C3 sensory routes. And then that sensation is traversed by the greater occipital nerve. So, front and the back of the cranium and the neck are connected together in a mesh. And therefore, most of the migraine patients will complain in some of the attacks they will still have, although the pain has started anteriorly, right, in the temple, but neck also hurts because the activation is happening together. Additional symptoms for clinical diagnostic importance are osmophobia, smell problem, triggered, as well as the migraine getting precipitated by certain smells, and very common in adults, up to reported 25 to 35%, a little less for the children. But for children, where the diagnosis of migraine becomes very difficult, the other histories are important, like histories of infantile colic, history of periodic vomiting, recurrent abdominal pain, the presence of motion sickness, vertigo or dizziness, and comorbid atopic disorder. So these are the additional symptoms you can ask for in case you are in doubt, especially in younger population. And the most important part, after you finish with the headache, the premonitory and the post-drome features, are the family history and the triggers. If you don't ask about the family history, nobody is going to tell you about that. But believe me, you will find about 60 to 70% will have a first-degree relative affected by headache. They will not say migraine. They say, oh, sometimes it happens. Sometimes they put a band on. Sometimes they take medicines. Sometimes my mother lies down on bed. Yes, I've seen that. Only if asked. And the triggers, you should routinely ask, because migraine is a disease which is typically triggered by a lot of triggering factors. And the most important are the environmental factors. As you know, hot, humid conditions are the commonest. Travel, stress, hypoglycemia, not eating, missing the meals, certain food items, alcohol, sleep deprivation, very, very important. And certain exercises. Some people get migraine because when they start exercising or assuming certain postures, and certain drugs. Of course, as you know, nitrates can trigger migraine. So therefore, this history of triggers, patient may not be initially aware of this. You need to ask about that. And you can make a small list and, kind of tick. Okay. And then your diagnosis becomes much, much easier. So let us take 3 scenarios. Now, this is the lady with episodes of bilateral throbbing headaches, both temples. The headaches are of long duration, lasting for many hours, sometimes a day or 2. Severe. There is nausea. She cannot tolerate noise, normal lights, and unable to perform routine activities of her household. She lies down. And there are a lot of comorbid psychiatric conditions. Like, recently her son has moved out of her house after marriage. So she is depressed. She's having anxiety. So this is basically a migraine, a long duration headache with all these systemic features. In contrast, you have this man, and you can see the photograph, episodes of intensely severe headaches, strictly side-logged, occurring for short duration, 30 minutes or so, 2 to 3 attacks per day for 1 month every alternate year. Severe side-logged autonomic symptoms, can't lie still. In contrast to migraine, where the patient prefers to lie still. Here they're agitated. They move around, they bang their head occasionally, right? And the duration is much less. So this is a typical cluster headache. And the third group, here the patient complains not just like headache. He says it's a band-like heaviness in the head, variable in duration, mild to moderate in intensity, no nausea, no vomiting, photophobia or phonophobia. Despite the headache or the heaviness, patient is able to work and move around. But heaviness responds partially to NSAIDs and keeps on coming back. And there are a lot of psychiatric issues. So therefore, it's called a tension type headache. You know the type, why it's called type? It is called type because we are not sure about the pathophysiology of this disorder. Is it because of the mental tension or some kind of tension in the muscles at the back and around the head? So it's a tension type. So these 3 distinctions, if you can make, then your day is made. Migraine, cluster headache, and tension type headache. In one condition, the patient is vegetative, migraine, agitative in cluster headache, and does not bother about the heaviness. He keeps on working with the tension. So this is important. Migraine classification also refers to many other varieties of migraine. Besides this, classical, kind of a thing where the migraine can happen with aura or without aura. Earlier, migraine with aura used to be called as classical migraine, and the other migraine used to be called as common migraine. Now they are no longer called like that. They are called as migraine without aura, and then migraine with aura. And then there are varieties like chronic migraine, complications of migraine, and various episodic syndromes that are seen in childhood. And there is an entity called probable migraine, in which all other features of migraine are fulfilled, but one. So they look like a very, very milder forms of migraine, correct? And maybe confused with tension type headache. So let us talk about aura a little bit. Auras are fully reversible visual, sensory, or language symptoms that precede or accompany headache. Clinically, migraine auras at times pose diagnostic challenge and can be mimicked by ischemia or seizures. There are three qualities of aura that you should remember. First is that it takes time. It takes more than 5 minutes, and usually lasts about 20-25 minutes. And it has a spreading or migratory quality. There is a positive phenomenon followed by a negative phenomenon. You have the scintillations, zigzag lines, which has been referred as fortification spectra, right? And followed by scotomas, the dark areas. And then auras tend to occur sequentially. First, they'll have a visual aura. In some patients, that will then go into have the sensory aura, and then they can have a language aura. So auras tend to occur sequentially. And so this is the picture. As you can see that there is outer front of zigzag line, the fortification, and then the central part of scotoma, right? This is typical of visual aura, and it spreading and migratory quality across the hemifield, right? Correct? And therefore, it can be easily distinguished if you can take this history from an epileptic aura or from a TIA, right? This migratory pattern taking so much of time with this kind of positive followed by negative never happens in our other two. Correct? And then you have this sensory. Now, sensory thing starts peripherally in the hands and then soon moves up the arm, up to the arm and the forearm, and from there it jumps to the face. So this is typical of migraine aura. Sometimes you can have complex visual, presentations like described by Lewis Carroll, Alice in the Wonderland kind of phenomena. Patients can see the objects as becoming small or large, metamorphoses, right? But they are very rare. They're uncommon. And many case reports are published now and then. Okay. And why do they occur? We have now known because people have imaged these auras and shown that there occurs a progressive wave of depolarization that moves from the posterior part of the brain, from the posterior cortex to anterior without maintaining any kind of respect for the boundaries. And then if you see that there is a drop in the cerebral blood flow, but initially there is a high. And this spike actually is responsible for that initial fortification factor, the positive symptoms. So this is a physiological, neurophysiological correlate of the aura that has been described by the patient. So remember this, that migratory quality spreads over a period of time, positive followed by negative, and then auras tend to occur sequentially. So if you see the categories of migraine with aura, there are various types which have been described. With a typical aura that lasts less than about 60 minutes. Sometimes atypical aura can also occur, and that is actually being defined elsewhere. The important point here is this, that the typical aura without headache, as the migraine patient ages, sometimes they are left without any headache, but aura continues. And that becomes a problem when they come for the first time to you with this visual aura symptoms, a 50+ person. So you are confused with TIA. So that patient requires investigation. Okay. Then the brainstem aura. There are a lot of brainstem syndromes can happen in brainstem aura. Dysarthria, vertigo, tinnitus, hyperacusis, diplopia, ataxia, or decreased level of consciousness. But remember, one thing never happens. That is, there is no motor component. Once the motor component happens, there is a weakness. Then you call it a hemiplegic migraine with all this symptomatology. And also, what doesn't happen is the retinal symptoms. And once the patient has the recurrent attacks of transient monoocular blindness. Now, as I said, aura was a hemifield, right? Here is one eye, monoocular blindness. So that's called retinal recurrent attack. So this might actually be confused with amaurosis fugax or retinal TIA, or sometimes an optic neuritis. Correct? So therefore, that needs to take into consideration. But these are rare conditions. You will not find too many. Of course, the brainstem aura is reasonably common in young females, in young adolescent females. You need to ask them these questions to find out whether there is an element of brainstem aura in them or not. And they might not be having a might or might not be having a visual aura, although most of them would have a component of visual aura as well. Then there is an entity which is the most disabling type of headache, is known as chronic migraine. It is a headache occurring for more than 15 days or more in a month, for more than 3 months. But at least 8 attacks are migrainous out of that. So if you see the evolution of migraine, this happens like this. It's episodic migraine, then that was sensitization, improper treatment. Over the years, the migraine gets transformed, and then they develop a chronic migraine. And then what happens? Their classical characteristic of migrainous features like throbbing headache changes to dull, nausea decreases, phonophobia decreases, severe pain changes to mild pain. So therefore, in many of the days, the phenotypes become tension type. And therefore, we make this mistake of diagnosing them as chronic tension type. Until and unless you have taken a good history and you know that still there are days where migrainous features type of headaches are occurring, you will miss the diagnosis of chronic migraine and you will say, oh, it's chronic tension type headache. And because of the continuous pain, they'll have a lot of comorbidity, especially the psychiatric comorbidity. And also, along with that, they will have a lot of intake of analgesics, triptans, and opioids. And that is the medication overuse. So these are the criteria. I'll not go into the criteria, but these patients are disabled. You can imagine half your life, 50%, 15 days, at least 15 days in a month is gone because of headache. So they are having a miserable life and therefore need special attention. And as I said, that many of them overuse medications and they have been classified based on the number of days they take, medication, what type of medications. For triptans, it's 10 days. For simple analgesics, it's 15 days per month. So this is called a medication overuse headache. Then we have the complications of migraine. They are uncommon, but occasionally you might be floored by this kind of symptom. And the first group is those with a known aura, right? Usually the visual aura is usually present in this. And then they would have a persistent aura without infarction, as I said, more than 1 week or more without evidence of infarction or neuroimaging. Sometimes they will get infarcted, they'll have a stroke, and you will have a neuroimaging correlate of the stroke. And sometimes the aura might trigger a seizure. So a seizure triggered by an attack of migraine with aura. But the more common variety is the other one without aura, and that is called the status migrainosus. These patients will keep on coming to your ER emergencies with a debilitating attack of migraine that is not resolving within 72 hours. 3 days, continuous, more than that, 4 days, 5 days. They keep on having this severe headaches and status, and they need admission and a rigorous treatment protocol to control their mind. Then in children, there are a lot of other episodic syndromes. At that time, they might not have severe headaches, but they have a situation where it is having a recurrent or cyclical pattern, like a cyclic vomiting syndrome, abdominal pain, recurrent paroxysmal vertigo attacks, and paroxysmal torticollis. For example, I have this, the youngest, child in my headache clinic. She is about 2.5 years old, and she's hardly able to communicate. But she says, as the parent says, okay, Papa, that kind of thing. And you get the history, and you know that my mother is having migraine. So your diagnosis, it becomes absolutely clear, right? And if you take the history of infantile colic in them, you'll definitely find that they have increased, prevalence of infantile colic. Now, this is abdominal migraine. And this patient later on developing severe migraine. Now you see that what he has done to his head by repeatedly banging his head over the wall. This can be very, very disabling. This, the episodic syndromes followed by full migraine features. Another way to distinguish various headache types is to have a diary. Now, this is the headache diary that we use, and you can see the entries there. And with that entry, whatever the patient is entering, you can actually diagnose migraine or attention type headache if there are problems in diagnosis in the first visit. So headache diaries are very, very important. You can ask them to make a diary of their own and just write down the symptoms and the frequency. There are certain, because I know many of you are very busy practitioners, and because it's very difficult to give even 10 minutes to a patient. So there are certain, validity screening questionnaires that are available. One is called ID migraine. It asks 3 questions. You feel nauseated or sick, light bothers you, or your activities get limited. If 2 or the 3 positive, then you know that you are possibly dealing with a migraine. Similarly, there is a 5-question, questionnaire called MSQ. Again, do you have frequent intense headaches? Do your headaches usually last for more than 4 hours? Do you usually suffer from nausea when you have headache? Does light or noise bother you when you have a headache? Does headache limit any of your physical or intellectual activity? So these are screening questionnaires. In fact, they can be answered by the patients themselves, and they can diagnose. So during our educational programs to the patients, we can use them. You can place it on your, clinic, so that they themselves can come up with you. Yes, doctor, I have 1 or 2 of this or 3 of these symptoms. And patient education along with doctor education is very important. I have been repeatedly giving lectures on Doordarshan and a lot of TVs and print media to educate about migraine problem, because I think that still neurologists are not that much oriented or that much keen to give headache medicine its proper place. And we need to educate the patients, because we cannot just think that only the patient will come to us. They'll come to the generalist. They'll go to the general practitioners, the MDs. So we need to educate. And therefore, in this paper where we have found out that, calculated the migraine about 211 million patients in India, a huge number. How do we treat them? And we need to have a small, simple algorithmic process. So basically, we need to exclude the red flags for possible secondary headaches, rule out all the thunderclap headaches. Then we distinguish between migraine, tension type headache, and trigeminal autonomic cephalgias, that is cluster headache. And then we have a simplified management option. So these are the 3 steps which will go a long way in you easing your diagnostic problem as well as treating the patients effectively. And finally, this is the latest thing that we are developing with IIT Delhi, is a computer-based assessment tool called Combat for diagnosis of primary headache disorders. And I think in coming 2 or 3 months, this will be available to you. We'll give it free of cost to everyone, but where you can, there are a set of questions, and it is based on a branching logic, questionnaire format, and it uses the ICSD-3 classification. So you can get any diagnosis of primary headache. And also you can distinguish between primary and secondary headache by using the Combat tool. And I think it will be useful for all of us to save our time and to make the diagnosis with precision. Thank you very much for your kind attention. So how do I get any questions? Will they come in the chat box?
Sagar, are we expecting? We'll just check now.
So if we can take up that later, and I think we can move to the next lecture, and that is by Dr. Girish. So can I have a introductory slide for Dr. Girish? He is going to talk about the migraine management in India, barriers and pitfalls. That what are the actual, difficulties that are faced by the physicians in India to properly diagnose migraine and treat them. And Dr. Girish is presently working as professor of neurology at NIMHANS, Bangalore. His area of interest is headache and stroke, just like me. And also, he is interested in delivering and developing modules for the quality services in healthcare. He has got a lot of publications in international and national journals. He has got a lot of funded projects, ICMR International Fellow in Stroke. He has done one of the very good, nice epidemiological survey of headache problems in India from Karnataka state. He has been a certified headache master school attendee from at Sydney, and he has, from CHO, he has got the advanced training for CPHIQ-IH. And he is, of course, a member of a lot of professional bodies, and he runs the headache and the stroke clinic at NIMHANS. And he's a very, very dear colleague of mine, and Dr. Girish, and is a very good speaker. So I invite Dr. Girish to kind of, share his screen and start his lecture. We can take up the questions after the lectures.
Thank you very much, sir, for the kind introduction. And at the outset, sir, I thank the organizers and you for bringing out this very important topic of headache and trying to improve the education and treatment aspect of the migraine. I think it will go in a long way in overcoming the various barriers I will be highlighting, sir. I will share my screen. Sir, my slide is visible, sir?
Yes, please go ahead.
So I will be trying to cover the migraine management in India, barriers and pitfalls under the following headings. First, I will try to see why it is important to know about the migraine and its barriers. And the barriers I will try to classify as demographic, as due to healthcare delivery organization, due to the migraine itself, and barriers due to the patient and other barriers. And also I will try to give some examples of pitfalls in migraine in the diagnosis and management. And in NIMHANS model, how we are trying to overcome these barriers and also overcome the pitfalls, and finally, conclusion. Now, if you go to the word meaning of barrier and pitfall, barrier is something that causes problems or makes it impossible for something to happen. So in the migraine, it is probably both diagnosis, management, and follow-up. And pitfall is a danger or difficulty, especially one that is hidden or obvious. So whenever we are trying to manage a patient by diagnosis and management, we will have some difficulty which we may not be aware. So these are the difference between the barrier and pitfall. Now, as sir told, the migraine is presenting with episodic headache, and commonly we see in a lady who presents with migraine without aura. And the important thing is it is a episodic and it is recurring. So it is very important to identify this. And less than 5% of the patients in Indian context, we see the aura, and we see chronic migraine around 5 to 10, and it increases to around 20% in the headache clinics. And very rarely we see patients of status migrainosus, child with a migraine, and familial hemiplegic migraine. So for majority of us will be seeing in a general OPD, in a neurology OPD, women with reproductive age migraine. And as we go for a headache clinic, we get a complicated patients. Now, why we should know the migraine barriers and pitfalls? Because as sir was also mentioning, it is the sixth most prevalent disorder among the 328 disorders listed in GBD-16, and the second commonest cause of disability after low back pain. And almost in all countries, it ranked top 10 causes. And another important thing is, as you see in this graph, that it is common in women and it is common in the reproductive age group and also in the highly productive age group of 20 to 40. And it is widely distributed around the world, and India is also involved. Now, the recent paper in Lancet Neurology describing the various neurological disorders in India and with disability show that non-communicable disorders form a major chunk of DALYs. And among them, after the stroke, migraines comes in the second. And as Sir highlighted in his paper also, there is a huge number of males and females migraine patients. They are there in the India. Now, if we see the prevalence of migraine, it is surprising that in our study we found it's a very high 22.8% of migraine prevalent in this part of India. And similar studies, I think, have been done by Sir and also in the East by Professor Das. And they also have noted a high prevalence of the migraine. Now, if you see the approaches of management of the migraine, it is when to suspect a migraine, how to diagnose a migraine, patient centricity and education, managing planning for acute treatment, preventive treatment, and migraine in special problems, and in a difficult patient and follow-up management of the various aspects of the migraine. So the barriers may be there in the various 10 fields of the migraine, and in some of the conditions, it will be more pronounced depending upon the area and ethnicity and distribution of the patient. So if you see the person who is going to manage this migraine, so it will be a primary care physician, and only 30% of the patients in the community will come to a medical practitioner for management. And you will be surprised to see that in our study, 84% of these patients are managed by the physicians. So why it is important to know this point? Because as I will be elucidating the various barriers, the most important chain link of management of primary care physicians, they are least equipped to manage the headache patients of migraine. So this is the important aspect which I want to highlight. Now, barriers to migraine care in India, we can go by various headings for better understanding and planning for the various measures to overcome the barriers. So as all of you know, that India is one of the large country with largest, probably now will become the highly populated country in the world. And we have around 17% of the world population, and now our population is expected to be around 1.4 billion. And in 2025 will become the most populous country probably. And 72% of the population lives in villages, and around 27.8 lives in the towns and the urban. And another important thing is we have multiple languages spoken in India, and the patients are coming to us with their own mother tongues and history. And as most important aspect of diagnosis of migraine or any headache will be the history only. So the presence of ability to interact with the patient will be most important. So you can imagine in our NIMHANS, because it's a national institute, we have residents coming from all over the India, and the majority of the headache patients who are coming are from the southern states. So you can imagine the difficulty in communicating because the history is the most important. So, and also if you see the each part of India, there is an enormous difference in the climatic condition, cultural beliefs, habits, literacy, and economic condition. The overpopulation, low literacy, poverty, urban-rural divide, presence of other diseases put direct and indirect effects on the help-seeking behaviors, perception of headache, and importance of care and management of the headache patients. And even if you see in a particular state, there are various differences. Like I want to highlight in my state, Karnataka, we have a northern part, we have a southern part, we have a coastal part and central part. The way the Kannada is spoken is totally different from all of them. And I am from north part of the Karnataka. When we come to southern part and the coastal, very difficult to understand the type of Kannada what we speak to these people. And similarly, vice versa will happen whenever they go. And the cultural beliefs are also totally different. So this is another challenging demographic pattern of our country. Now, if you come to this other aspects of this demography, the beliefs of the patient and attitudes of health-seeking behavior also change. And in 80% of the care is provided by the private sector, and only 20% by the government sector, and insurance systems are lacking. So in this way, the demographic barriers play a major role in the care and morbidity and epidemiology of the migraine disorder. Now, second aspect of barriers are due to healthcare delivery organization. Now, you know that India is the probably sometimes it becomes the fifth and sometimes sixth largest economy in the world by nominal GDP, and third largest by purchasing power of parity. And the growth rate of India is 7 to 9%. But the unfortunate thing is it is not accompanied by a high level of social development. The recent survey show that India spends less than 4% of its budget on health, and it is ranked in 155th in the health index, spending index, and probably it is one of the lowest budgets for the GDP. And compared to us, Japan spends around 23.6% of the budget for the health. The revised estimate for 1920 and budgetary expenditure for the health, which is expected in 2021, shows 1.5 and 1.8% of GDP respectively. Probably it is growing because of the presence of COVID, and probably the expenditure is going in that way. Now, in this organization, as I told earlier also, majority is taken by the healthcare by the private, and out of the pocket expenditure for the patient is the most important things. And all combined central, state and local, they spend only around 24% of the money for these patients. And the NGO sector is almost non-existent in terms of spending on the health services. Now, also, if you see the organization of the health system, in the government setup, we have a sub-center, and this is linked to a PHC. Then this is linked to a taluka hospital, district hospital, and tertiary and medical colleges. In private setup, which are predominantly in the taluk places or in district, are managed by a hospital setup where probably a specialized care and surgical care is given importance. So there is a huge difference in the doctors' availability and beds availability also in the rural and urban areas. Now, if you see the pathways, the most important thing, supposing we think that a patient wants to go to a primary health care for his headache. So in majority of the patient in the primary healthcare center, we may have a doctor, but the major crux is on the communicable and non-communicable diseases, infectious diseases, and maternal child health care. And many of them may be functioning only during a few hours of the time, and primary health units may not have a doctor also. So possibility that patient will be evaluated for migraine, and its prophylaxis is required, what are the comorbidities is unlikely, and probably he will end up in taking an analgesic rather than any other evaluation or education of the patient. Now the same patient you think comes to our institute, what will happen? Per day we are having now, before it was 200 only, per day now neurology patient 250 to 300 are coming, and majority will be for the second opinion or third opinion, or for a admission from a chronic undiagnosable disease. So probably the headaches will be seen by a junior resident or a resident who is managing the general neurological patient. So backache, headache, and vertigo will go to them, and probably the competence may not be there. So these are the various barriers I have seen over the years in the management of this headache patient, especially migraine, due to the organization. So in end, what majority of us we have seen is a patient with recurring migraine will end up in taking different medication with different doctors, with different practicing system, and with few scan without realizing the disease they are suffering. Now, if you take the migraine itself, it also acts as a barrier, because as sir was telling, probably around 10 years back, we didn't have much epidemiological data on the burden of the migraine, but it is improving now. And we have a study from north from Dr. Debashish, south from our center, and east from Dr. Das. And probably the earlier studies which were not taking migraine as a questionnaire in the study, probably they are underestimated the thing. So it is improving gradually. Now, other important things are the awareness among the patients regarding migraine is less compared to the chest pain, and probably instead of going to a doctor, they will take a medicine and be done with it. The Indian context, disability and assessment of the economic burden over the country has not been done. And because this is not a life-threatening and is a recurring, so in majority of the national health programs, the diseases which are associated with mortality, they are mostly covered. And so there is no importance given to this headache disorders in our national programs. Now, coming to the barriers related to the patient, when we go through various patients, we come across various myths and misconceptions in them regarding migraine. There will be delays in seeking the treatment, fear of side effects and allopathic drugs, poor compliance, and inability to understand the migraine and poor control of triggers. And many of you will be knowing, majority of them tell that their migraine is due to a defect in the vision, acidity, stomach upset, emotional upset, and sinusitis. So these are the common understanding of migraine by the patients. So in all these things, what happens is there will be delay in diagnosis, delay in treatment, and the patient also expects that a migraine will be cured by a single doctor consultation, and probably there may not be detailed experience because of the busyness of the majority of the physicians, and finally end up in changing the doctors and the doctor stream and medicine stream of different things. Now, we reviewed the various barriers in one of our study done around 10 years back, and you will be surprised that patients comes to at least before coming to NIMHANS, they go to around four physicians, different physicians before a diagnosis of migraine is made in NIMHANS. And in another study, we saw around 330 patients of migraine. You will be surprised to know that only 1/3 of the patients knew that they were suffering from the migraine, and only 25% of the patients were taking preventive treatments who were eligible. That is only 25%, 1/4 of them are on prophylactic medications. Now, other barriers, if you consider, are very limited research from lower and middle income countries like India. But thanks to our seniors like Professor Ravi Shankar and Professor Debashish, this is changing, and we are having a lot of interest in publications over the years. Now, coming to the other barrier of training medical professions, we at NIMHANS did a small study called as A-Steps Headache, that is assessment, short-term training, education in primary and secondary headaches for non-neurologists, because many students come to our NIMHANS for 2 months, 3 months training in neurology. So we thought that we use this opportunity to assess their knowledge in the headache. And I am presenting predominantly in the headache and migraine aspect in this presentation. So majority were general medicine and psychiatry, and fewer pediatric residents. And you'll be surprised to see that only 15% of them had received any training in migraine. And if you see the hours of training they had received, it is almost 1/6 what the other general medicine topics and cardiological and pulmonology things they were taught. And same thing is depicted in the their self grading of how training is there in them regarding diagnosis, investigation, and treatment. Very few of them, they told that it is adequate. So majority of them felt that it is inadequate. Now, various practice parameters, what they are using, they use ophthalmoscope in only 33% of the patient, headache diary, as I was highlighting the importance, 13%, and ICHT criteria in very few patients, very few doctors were using that. And if we go for the migraine, probably they were medium comfortable in diagnosis, investigations, and treatment. So there is a huge gap in the physicians in the migraine. Now, if you go to the villages and primary health center, so what happens? So we studied in a MPH thesis last year, and we studied a Kolar district, 5 talukas, And the migraine medical officers, they are the medical officers in the primary health centers. 60% were confident of identifying migraine. And surprisingly, tension type of headache, they were more confident. And secondary headaches and headache mimickers, it was very less exposure to these physicians. Now, other government, insurance, and non-governmental organization participation is almost nil. Now, other barriers, as sir was highlighting, public education is hardly any emphasis on public education in the migraine and headache disorder. So most of them end up in consulting multiple specialists of allopathic like ophthalmologists, gastroenterologists, physicians, and neurologists, and traditional medical practitioners. And the educated and affordable patients get a CT scan and hardly any emphasis on preventive aspects to form avoiding the triggers and lifestyle modifications, which should be emphasized. Now, this is about India, and you will be surprised to see that the recent study from US also, they classified the various barriers into the four, like consultation, then accurate diagnosis, appropriate pharmacological treatment, and no MOH. And you will be surprised that in episodic migraine, only 8.5% of all migraine patients were able to cross all the barriers. And in chronic migraine, only 1.8% were crossed all the four barriers. So it is very obvious that all over the world and India, there are a lot of barriers, and these barriers are specific due to various factors I classified and explained to you. Now, in spite of all these barriers, we had one more barrier from the last 2 years, and this is COVID. And sir has come out with a very nice article on COVID-19 pandemic and its effect. And there are other articles also available. So those who are interested can go through. Probably the outpatient services were severely hindered in tertiary care and secondary and primary health centers. So probably all the patients might have suffered. Now, coming to the pitfalls. So now, if we go to the pitfalls where unknowingly we will make a diagnosis, probably we make a mistakes in diagnosis and management. So I want to bring out the various case scenarios which I have seen over the last few years to highlight how we can identify this and how we can avoid this. Now, access to care, as I told, in the primary health center, what are the problems? And in the tertiary care center, what is the problem? So the how to overcome, I will be discussing in the NIMHANS model. Now, diagnostic challenges. The patient one is a 56-year-old lady who has a migraine of unilateral headache from the last 28 years. And you can imagine from 28 years, she is getting good benefit. And from 1 month, suddenly what happens is her headache becomes side locked and it becomes continuous and daily. So we were wondering why this sudden change is happening when in the 6th decade. So without wasting any time, we did a CT angio and DSA, and to our surprise, we can see this aneurysm in the ICA. And another important group of patients, what I have seen is the co-occurrence of IIH and migraine. So again, as Dr. Debashish was emphasizing,
Hello.
Sir, can you hear us, sir?
Is it? Hello.
I think there's a problem at his hand because I can't either hear her or
He got
not.
disconnected.
Dr. Girish?
I think he got disconnected, sir.
Okay. Okay, let him connect. Till that time, Dr. Pandey, can you make a call to him and find out what is happening?
Yes, sir, sure.
And till that time, I think to carry on to the problem that he has highlighted very nicely, I would like to take the opinion of the other panelists. And there have been some questions also on the panel. Dr. Sumit, nice to see you. You have joined in. So
Sir, I was
you
in a
have
meeting,
worked-
sir. I'm so sorry I'm late. I
No, no.
really don't know the question which was raised.
No, so question is, no, it has been raised just now that you have worked in a, premier institute like All India Institute, and now you are in a premier private institute. So what are the principal barriers you think that migraine patients are facing in India?
I think, sir, it is the understanding of the disease.
Mhm.
I think there's only one single barrier. If they can understand their disease, that is going to take them a long way. They think that this is one thing which is just like malaria or typhoid, that you take the medicines for 15 days, 20 days, 1 month, 2 weeks, 1 week, and you're going to be cured of it.
Okay. So,
But it
I think
is,
for that,
I-
I think the patient education is very important. What do you think?
I think I agree, sir. I think Dr. Girish is already there.
Yeah, Dr. Girish, have you joined in?
Yes, sir. Yes,
Yeah,
sir.
yeah, I can see him,
Yes.
sir.
So you can again share your screen and
Yes, sir. Yes, sir.
finish your presentation.
Yes, sir. Sorry. So this patient had a, sir, you are able to hear me, sir?
Yes, yes.
Yes. So this patient has a very characteristic symptoms of weakness. And as sir told, it was associated with previous history and family history of migraine, but no weaknesses. So we had a strong possibility of familial hemiplegic migraine, and it turned out to be a familial hemiplegic migraine. Now, another important thing what we have learned in our chronic daily headache and chronic migraine group is the symptoms of migraine may become less prominent in the chronic group. So that is the another pitfall for the diagnosis of the chronic migraine. Now, in therapy, the most important aspect what I want to highlight is majority of the patients are women in the childbearing age. Selection of the treatment depends upon the onset of the illness to the peak of the headache that we should think. And in chronic patients, the use of medications and comorbidities should be matched. In the follow-up, the pitfalls are predominantly reduction in the number of visits to us. Now, how to overcome these barriers? This is a picture from Manji, and he is Mr. Nayak, who recently received Padma Shri by putting a tunnel in his field to get the water. Now, if you see the structured headache services solution to the ill health burden of headache, in this paper, it is come out that there should be 3 levels: general primary care, level 2 special interest headache care, and probably the institutional headache centers. And large number of patients should be managed by the primary headache centers, and then district, and very minimal in the tertiary care. And we can have either a layered or hub and spoke model of the headaches. Then, so how we came about these various barriers in NIMHANS, I will go through the various models. In 2009, we started a epidemiological study to find out the prevalence of the headache. This is our team, Tim Steiner, Dr. Girish, and Dr. Gururaj. We went around the various cities and villages and did the primary prevalence studies of the various headache disorders. Once we had a headache prevalence, we put for a small grant for the World Federation of Neurology for establishing the headache services in the city of Bangalore. And over the years, our headache clinic has moved into a specialty clinic at NIMHANS, and we operate 2 days in a month. And then we thought that we have an opportunity to train the physicians. So we started this thesis and started training the physicians who are coming to training in neurology in NIMHANS. And then we popularized use of headache diary. Then, as sir was telling, to improve the awareness about the headache in various regional and English newspaper and various print media, we made a group and tried and arranged various public education in a place where a lot of patients are visiting. and prepared the pamphlets for the education and built up a team involving neurology, psychiatry, and psychosocial workers, and also come out with local physicians with review articles on headache, how to they manage. And finally, now from the last 3 months, NIMHANS under Professor Suvarna has launched a program called as Brain Health Initiative, where 4 common neurological disorders, headache, stroke, and epilepsy, and dementia, we are trying to train the various primary health centers, secondary health centers in the district, and try to see whether this model works. And I am in charge of the headache part of that Brain Health Initiative, and we are starting this study in the Bangalore, Mandya, and Kolar hospitals. So these are the various physicians who are involved in the activities of brain health initiation. Now, how to overcome the pitfalls? As Professor Debashish told, the identifying the various aspects of the migraine, whether it's episodic and chronic, and identifying the red flags is the most important aspect of the diagnosis of the migraine and avoiding the pitfalls. And treatment is knowing the various acute and chronic drugs and important side effects and when to avoid them. This is the important aspect of migraine management pitfall. Now, my important thing is, sir, it is my request that probably over years, we will have Ayushman Bharat covering majority of the treatment and the subsidizing. Probably we should all try for inclusion of headache diseases, OPD consultations and treatment in Ayushman Bharat insurance scheme. So in conclusion, though migraine has emerged as one of the major neurological disorder with disability in the world and India, especially in India, it is data is evolving and needs to be strengthened. There are particular and peculiar barriers for the diagnosis and management of patients in India, and we should appreciate these barriers regionally, and efforts should be done to help to improve the management of these patients. Thank you very much.
Thank you, Dr. Girish, for a very, very lucid and comprehensive lecture on on this very, very important aspect in headache medicine, which is not being touched actually. And I think it is for the common good for all of us to know about that, what all kind of situation that is prevalent in India, and that can pose various challenges in terms of proper therapy, diagnosis, and of course the reach of the program, as you said. And you rightly said that the headache services should be integrated with the national programs, and so that it can benefit millions of people, right? So we were asking when you were off the thing, there has been a question on this actually, that in your view, that what is the most important kind of barrier, and what are the most important difficulty from patient perspective and from physician perspective in India in your headache practice?
Sir, I think it cannot be a common to all places, sir. It varies to places where we are practicing, sir, and the site where we are practicing, sir. I think all of us should know the barriers are existing in that place and try to highlight which one is the most important and which one we can overcome, sir. And over the time, how a policy matter or a project or something we can start, which will help us to overcome those barriers. Like it is my thinking. Like
your voice is breaking.
Because we cannot give a dedicated time establishing the sir at NIMHANS, it was establishing the headache services and starting a special care for them and starting the project to help to train the physicians who are coming to us. So that was the important.
So I
try to see which one we can try to do.
Okay, I agree with you that it has to be place specific and institution specific, because there are a lot of issues in that also. But in general, say for example, if you see that the migraine patients, as you've shown that they are receiving so less number are receiving actually the preventive drugs which are actually needed by them. So there is a lot of gap, huge gap there. And so how do you kind of tell the physicians, friends of ours who are actually in this program and in general, what is the scope of providing the right kind of medications, good, safe medications to migraine patients?
Yes, sir. Sir, I think all the physicians should be very well versed with few acute treatments, which are specific and non-specific, sir. Non-specific, like in children, paracetamol, and in adults, probably naproxen. They should know the dose, they should know the side effects. And regarding the preventive therapy, sir, they should know which drugs to be started, how to start, and how to titrate these medicines. And they should know which are the side effects and group of patients whom they should avoid. So, sir, if they practice 2-3 preventive medicines and 2-3 acute treatment medicine, and over practice, they become confident in them that, sir, they will overcome this. And they should use headache diary, sir. Whichever simple one they can follow, they can use that headache diary, and then they should titrate. And one headache pamphlet or some education material they can make and give it to the patients when they come. It will go a long way, sir.
Right. Absolutely correct. And I think in this context, basically somebody asked about the deficiency of iron, for example, causing migraine. So in this context, I think we'll straight away go to the next lecture first, because that is going to talk about the very important aspect of nutraceuticals and, vitamins, minerals, and other neuromodulators for migraine prophylaxis. I think that's a very, very important topic for today, because I think there is a great scope of using these, less costly and drugs which are having minimal side effects. And so we will answer that question about the iron deficiency later after this lecture. But let us invite Dr. Bhargavi Ramanujam. Dr. Bhargavi, are you there? You can share your screen.
Yes, sir.
Before that, I'd like to introduce you. Dr. Bhargavi is a neurologist. She was formerly working as assistant professor of neurology at All India Institute, and I think she has just quitted that. And she has been an MBBS from my alma mater, Maulana Azad Medical College. And she has done DM neurology from PGMR and Ram Manohar Lohia Hospital. She has actually been one of the scientists working at the Center of Excellence for Epilepsy, working closely with Manjari, I think, for a long time. And her research interests are drug resistant epilepsy, PENS, migraine prophylaxis. She has got a lot of publication in index journals, and she is also assisting the editorship for Neurology India. And because of my privilege of inviting and getting the help of all the junior staff who are very, very receptive to my advice and to my calls. She has also now joined and taking active interest in headache medicine, and she is basically looking forward to a lot of work in headache medicine as well. And recently, she has been preparing a paper on the role of nutraceuticals, especially the vitamins, on migraine prophylaxis. And so therefore, I would not waste further time and request Dr. Bhargavi to kindly share her screen and present her talk on the role of nutraceuticals in migraine. And that's a very important topic, because I think that that's one thing which all of us can prescribe and afford in India. Dr. Bhargavi, please.
Thank you, sir. Hope you can see my slides, sir. I'll just put it on full screen.
Yes, we can see it. Please go ahead.
So a very good evening to my respected seniors and all the esteemed delegates. And I really thank Debashish sir and the CME Foundation for this opportunity. I will be talking about the use of nutraceuticals in migraine prophylaxis. I hope you can see the quote by Hippocrates. He says, our food should be our medicine, or I would interpret it as otherwise medicines should be our food. So what are nutraceuticals? Nutraceuticals the term was coined by from nutrition and pharmaceutical in 1989 by Dr. Stephen D. Felice. He was the founder and the chairman of the Foundation for Innovation in Medicine. He defined it as a food or a part of food that provides medical or health benefits, including the prevention and or treatment of a disease. So I think in order to understand the biological basis of the trials conducted with these substances, which we call nutraceuticals, as prophylactic agents for migraine, we should look at the pathophysiology very much in brief of migraine. So we all know about the cortical spreading depression being the key pathophysiological basis of migraine aura, and how it activates the trigeminal-vascular neurons and the meningeal nociceptors. We do know to an extent that a common factor for almost all migraine triggers seems to be the reactive oxygen species, or the ROS. These molecules in the oxidative stress pathway can modulate the CSD, the cortical spreading depression, via the transient receptor potential ankyrin type 1 channels. So carrying on with the pathophysiology, there seems to be frequent headaches in several mitochondrial disorders. Now, it was postulated that deficient oxidative phosphorylation led to energy failure in neurons and astrocytes, which allowed high intracellular penetration of calcium, as well as excessive production of reactive oxygen species, triggering migraine mechanisms, which includes the CSD. So researchers have found low activity of the superoxide dismutase, high levels of lactate and pyruvate, low ratios of phosphocreatinin in inorganic phosphate, and NAA and choline in migraineurs compared to controls. So there is further evidence of the involvement of abnormal mitochondria, the genetic evidence in the form of association of common mitochondrial DNA polymorphisms with pediatric cyclic migraine vomiting syndrome and migraine, and Pol gene mutations that can cause disease through impaired mitochondrial DNA replication, including migraine. So even demonstration of ragged red fibers, COX-negative fibers, accumulation of subsarcolemmal mitochondria, and giant mitochondria with paracrystalline inclusions in the muscle biopsy specimens of migraine patients is, well, morphological evidence of mitochondria being involved. Now, let's move on to the nutraceuticals, and we will discuss how they affect the pathophysiology as and when we come to them. So I have classified the nutraceuticals that have been studied in migraine prophylaxis in some broad categories of migraines, vitamins, minerals, some botanicals, and other supplements like lipids, which may not be a complete list. This definitely is not a complete list. However, we will be going through some details in the further slides. So let's start with the vitamins. Since out of this long list of vitamins, which we know very well, the red ones I will be describing in further detail. Vitamin B2 or riboflavin is the best or the most well studied. So the potential mechanism of involvement of riboflavin in migraine pathogenesis is that it is a precursor of flavin mononucleotide, and it is and that of flavin adenine dinucleotide, which catalyze the activity of flavoenzymes of the mitochondrial respiratory chain. And riboflavin, along with vitamin B12, folic acid, and pyridoxine, they are all required as cofactors for homocysteine metabolism as well. So as mentioned before, this is the most well-studied vitamin, and it has 8 RCTs at least, with riboflavin alone as the interventional agent. with age ranges pediatric up to adult, 65 years. So it all probably started with Shonen, Dr. Shonen, who and his colleagues in 1994. They conducted an uncontrolled trial with 25 subjects, and they found that 400 milligrams of riboflavin taken daily significantly reduced the number of migraine days and the severity of headache. Then the same group in 1998 published a double-blind randomized control trial where the sample size of 54 adults, 18 to 65 years of age, had 50% responder rate and reduced migraine days, significantly less compared to the control population. And there was also significant reduction which was noted in the duration and the severity of headache in the riboflavin group. So while many studies were carried out in the in adult population, some like the Talibian et al. Was carried out in amongst children in the 5 to 13-year-old age group. In this study, there were 90 children who were divided into 3 groups randomly and given 100, 200 or milligrams of riboflavin or placebo. Here they found that at the end of 3 months, the group on the higher dose of riboflavin had a significant improvement in the headache parameters. And the 2 other trials that I would like to mention here are the Nambiar et al. And Rahimdel et al. Here they compared 100 milligrams and 400 milligrams respectively of riboflavin to already established propranolol and valproate. And they did not find any significant differences in the frequency of headache, duration or severity after 3 months and even after 6 months, according to Nambiar et al. Now, moving on to vitamin D. Vitamin D is said to reduce the activity of nitric oxide synthetase, and it lowers the activity of NO, which is supposed to be one of the many agents triggering the trigeminal-vascular nociceptors. Its deficiency may also reduce magnesium levels and levels of serotonin, dopamine, and it may increase the CGRP. So there are 3 RCTs or randomized trials, in which they have used different dosage schedules of vitamin D, and they've compared it to placebo. Time period of observation has been around 3 months to 4 months, and almost all of them are in 2 of them at least are in adult patients, and 1 has covered 10-year onwards, and all 3 have shown improvement in mean headache frequency at least, and in 1 or 2 duration as well as severity has been benefited. These 2 studies are non-randomized trials and done in children and adolescents. These 2 studies, they have divided their pediatric and adolescent population subjects with migraine into groups based on their serum vitamin D levels. And they found that those with deficiencies, when they were supplemented for a period of say 3 months, had significantly better headache profile or outcome. So deficiencies of these vitamins, of other B vitamins and vitamin E, also could, particularly vitamin B, like folic acid, vitamin B12, vitamin B6 or pyridoxine, would lead to raised levels of homocysteine. Hyperhomocysteinemia in turn could result in elevated levels of homocystic acid, which is an excitotoxin. And it could activate the trigeminal-vascular system, triggering migraine attacks. And it also induces, hyperhomocysteinemia is also said to induce endothelin-1, which in turn is said to induce the cortical spreading depression. This has been seen in a study done in rats. So this is the pathophysiology behind, this is the biological basis of these 3 B vitamins being used for migraine prophylaxis. Vitamin E may be effective in menstrual migraine, by inhibiting the conversion of arachidonic acid to prostaglandin, which of these levels of which are seen to be higher in certain phases of the menstrual cycle. Its action also may be through the antioxidant effect by countering the ROS, or the reactive oxygen species, that are now linked, of course, to the CSD. So this table summarizes the evidence of efficacy of these vitamins. I have mainly taken in all, wherever possible, where vitamins or any other agents are taken as monotherapy in migraine prophylaxis. So in the first study, vitamin E, Zai S et al., they have used, it's a placebo-controlled study, double-blinded, where they have given vitamin E and placebo soft gels to 65 young nursing students who had menstrual migraine. They've given randomly for one cycle and then crossed over in the next cycle, and they've found that the reduction in mean duration and severity and disability were significantly more in the vitamin E cycle compared to the placebo cycle. So, however, folic acid has not shown any benefit on headache parameters alone, though it did show benefit with on combination with pyridoxine in this study by Askari et al. And pyridoxine alone also in a randomized trial, it has done by Sadeghi et al. It has shown significant effects on headache duration and severity. Whereas vitamin B12 has been used in the form of intranasal cobalamin in an uncontrolled trial, and it showed some effect in, or significant effect in, frequency, disability, and responder rate. So now going over to the lone mineral that I am covering, which is magnesium. It is supposed to be the fourth most abundant cation in human body after calcium, sodium, potassium, calcium. And it is said to be involved in over 600 enzymatic reactions. And this includes those involved in energy production. It inhibits the calcium influx in neurons by blocking NMDARs, and which initiate and maintain the sensitization after a nociceptive stimulation. So NMDA receptors may facilitate cortical spreading depression, and thus may be a target for anti-migraine treatment as well. So therefore, the mechanism of action of magnesium seems to be blocking calcium channels in neurons and therefore decreasing the CGRP levels. So there are several randomized trials with magnesium, either alone or in combination with other nutraceuticals. Two of these were in children. The last but one, and the third from the bottom. And all these studies, out of all these studies, only two have shown little difference between the groups. Otherwise, almost all the studies have shown benefit. I would like to highlight a recent study by Khani et al., which is the last one here listed. And the subjects in this study, the subjects with at least 4 monthly attacks were randomized, and they were assigned to three groups, one with sodium valproate, one with magnesium with sodium valproate, and another with the last with magnesium alone for 3 months. And the study obtained results revealed that magnesium could enhance the anti-migraine properties of sodium valproate in combination therapy. Alone, it was probably not effective, but it does enhance the anti-migraine properties. Therefore, maybe the dosage of sodium valproate could be reduced. Moving on to coenzyme Q10. Coenzyme Q10 is the major cellular function of which is electron transport in the electron transport chain within the mitochondria. So coenzyme Q transports electrons between either complex 1 or 2 to complex 3 by accepting electrons from NADH or succinate, respectively. And it also prevents excessive, thus it actually prevents excessive reactive oxygen oxidative species production. And there are a lot of studies done with coenzyme Q10 as the investigational drug. And 2 recent meta-analyses have been published. One of them being by Sazali et al. And they have looked at 6 studies, and they have seen that there is benefit in the duration and frequency of migraine attacks with magnesium, either in combination or alone. This other, the forest plot that I have shown here, it is the more recent meta-analysis, which is by Parohan et al. And this shows that this diamond at the bottom of the forest chart, this seems to be more in favor. This tells that it is more in favor of the investigational drug rather than the placebo. And it is, since it is not touching the null line, it seems to be effective. And this forest plot is for the parameter of frequency of attacks. The other 2 parameters don't seem to be significantly benefited, that is duration and the severity, according to this study by Parohan et al. Moving on to polyunsaturated fatty acids, or the PUFA, they are supposed to have anti-vasopressor and anti-inflammatory properties. However, aside from this first study, which I have listed here by Wagner et al. In 1997, which was an open label study with a combination of PUFA with vitamins, other antioxidants, and multiple lifestyle interventions done in adults. These were patients with IHS criteria diagnosed migraine, this study did not show any. This study showed a major reduction in by 86% of 129 patients adult patients of migraine after 6 months. However, both the others that I have listed here, which were actually randomized, double-blind randomized controlled trials, did not show any positive results. Lipoic acid, this also, like PUFA, has antioxidant properties. It is supposed to regenerate other antioxidants, and it improves mitochondrial function, including that of superoxide dismutase. There was one multicentric study with 54 migraineers, which I would like to talk about, with thioptic acid versus placebo given for 3 months. And there was a significant reduction of attack frequency, headache days, as well as headache severity in the intervention group. However, there was no significant change in the placebo group, nor was the parameter of 50% responder rate significantly affected in either of the 2 groups. Ali et al., they noted a reduction in mean monthly migraine attacks in 40 secondary school students with migraine. And what they said was that the effect was most pronounced with the combination therapy of lipoic acid with topiramate. And topiramate was much better tolerated with lipoic acid rather than in monotherapy. So the last group that I'm going to discuss is that of botanicals. So there are these 2, feverfew and butterbur. These 2 are the 2 botanicals or the 2 herbs that I would highlight. And these are the most well-studied of all the botanicals. And feverfew is, the scientific name is Tenacitum parthenium. It is called the jungli kunain in Hindi, apparently. And but it is a very commonly found flower. If we look around us, it is a commonly found flowering plant, and its most biologically active principle is the parthenolide, and it has anti-inflammatory properties, and it prevents platelet aggregation. It is available in India. The extract is available in India as powder form. The other one is butterbur, which is also, its scientific name is Petacites hybridus. Its active ingredients are petasin and isopetasin. These have vasodilatory and anti-inflammatory properties. The anti-inflammatory properties are by way of leukotriene and inhibition of leukotriene synthesis. And this also is available in powder form in India. And there are at least 5 studies which I will quote, which I have listed here. 4 with feverfew extract and 1 with butterbur, and all of them, these are against placebo, that they have been assessed, and they are either in alone feverfew extract, particularly in the first study by Pfaffernath et al, and maybe with in combination with. So these are. There are several studies in combination with other antioxidants as well as vitamins. However, the first study done in 2002, the Pfaffernath et al., this is only in which this is the only one which did not show any major or significant reduction in the headache parameters. Only the post hoc analysis showed benefit. Otherwise, all the other 3 with feverfew have shown significant reduction in frequency or in the number of, in the severity or mean number of days compared to placebo. The study by Grossman and et al., this study has used the petocyte or butterbur extract against placebo. And this has shown reduction in all 3 headache parameters compared to baseline in 60 migraine patients. So this was a randomized control trial as well. The last nutraceutical that I will be talking about is the ginkgolide B or ginkgo biloba tree extract, which is one of the oldest living tree species on the earth. And the ginkgolide B, which is the active ingredient, is a platelet activating factor receptor antagonist, and the PAF is a pro-inflammatory agent that modulates cytokine release, and it induces more serotonin secretion in patients with migraine compared to those with controls. There are about 4 open label studies with ginkgo in combination with various other vitamins and antioxidants, 1 in adults and 3 in children, all of which showed significant benefit. So this list is not exhaustive. This is, I have left out one a very favorite agent called curcumin, which is the active ingredient of turmeric. But I haven't covered it because it doesn't have, I would say, any interventional studies, too many interventional studies or convincing data, basically. So now I would move on to this evidence-based guidelines brought out by the American Academy of Neurology. This was about 10 years back or so, 2012, where they have given a level A or medications with established efficacy category to butterbur or petacites here in the first column, and to level B, medications which are probably effective category to magnesium, to feverfew, and to riboflavin. And medications or level C, which is medications which are possibly effective to coenzyme Q10. An inadequate or conflicting data to support or refute medications category has been assigned to omega-3, which I haven't directly covered here. However, this is a more recent American Headache Society consensus statement, which was brought out in March 2021, which has not mentioned any nutraceutical, has left out reviewing these nutraceuticals. So I would summarize with Some nutraceuticals, I'm a little biased towards vitamins. So I would say that vitamin B2 or riboflavin and vitamin D3, they at least have some evidence of benefit, and they still do need large studies to prove their efficacy. Since the advantages are big, at least for our side of the world, the costs are much lower. And again, hardly any adverse effects have been listed. So I also didn't go about telling anything about the adverse effects, because hardly any were listed in any of these trials. And even now, after multiple studies with vitamins also, the dosage schedules are uncertain, and those also require further research on a larger scale. So thank everybody for a patient hearing.
Thank you, Dr. Bhargavi, for a comprehensive review of the available literature on use of nutraceuticals, in migraine. And I would completely agree with you that at least as of now, the evidence for the use of riboflavin and vitamin D are pretty robust. They are still, there have been at least 2 or more randomized clinical trials, and that is what is required actually. The problem is this, that these drugs do not come to the forefront because obviously there is a significant drug lobby which promotes the other drugs and the newer drugs.
Yes.
So, but for a developing nation like ours, where the cost is a major issue and adverse effects is a major issue, I think this can all be, kind of accommodated as an add-on, if not as a single agent for prophylaxis. That would be my take. But before we go to the next lecture by Sumit, I think there are a few questions which are already asked for you.
I have a question.
First, yes, Sumit, you start with your question.
So it was interesting presentation. We actually did a randomized trial with riboflavin, and I am really surprised that she did not mention it. So this guy was an observer from, I think, out of India. I don't remember what time. And we had actually at that time, riboflavin was not available. So we had asked Shreya Pharmaceuticals, which is the only supplier of pure riboflavin, 400 milligrams. And we did a randomized trial with the riboflavin in some patients, and we found interesting results. And the second thing is that like vitamin D, riboflavin, vitamin B12, I agree that they should have a role, but at the same time, I think about 92% of Indians have a deficiency of vitamin D, and about 20% of patients in India have migraine. So if we do a logistic regression, then only we can understand whether actually vitamin B12 or vitamin deficiency of any type, or like vitamin D, vitamin B2 or vitamin B12 are actually even associated with migraine. So it's a very, very wide area where very large studies are required, because migraine is very common, vitamin deficiency in India is very common, and therefore an association with between the two is also going to be very common.
Yes, I agree, because all these studies that I have, I'm sorry I missed out yours, but and yeah, I found all of them have not more than 100 subjects. The sample sizes have been very small, and I completely agree. Whenever we get a patient's vitamin D level done, it's almost always going to come out to be low. It's a surprise to find it normal. And so it is very difficult to prove anything by just doing a small study. It has to be on a very, very large scale so that we prove such a connection exists in the first place. In the meantime, maybe we can be guided by the serum levels. So we treat the serum levels and keep the patient on follow-up for the headache response as well.
I think, Dr. Bhargavi, the point is here, the most of the studies, if you see, they have used doses which are supraphysiologic, right?
Yes.
Right. So therefore, I think, and they have shown, even if less in number, they have shown the benefit. So at least, I mean, obviously now doing a placebo control trial when there is already existent, well-proven therapeutic agents available for migraine prevention is difficult. So therefore, what my take would be that if at all, then they can be an add-on. And you are right that if you can, anyway, we get, a lot of migraine patients also complain of myalgias, body aches, neck pain, torso pain, and we do get vitamin D levels done for them, and then we do supplement them. So it is possible that that might be of help to them otherwise also. The question here is, of course, that what is the ideal dose of riboflavin, and does melatonin has any effect in migraine?
Melatonin I have not covered because there was again not a long list of studies. So, but melatonin, yes, in the small study that I did see, did show benefit. And even vitamin D is supposed to have an effect on melatonin levels, as I showed in the diagram.
What is the ideal dose of riboflavin?
Riboflavin, anyway, ideal dosages are a difficult question, sir, but anywhere between 200 to 400 milligrams, I would say we can try.
Yes.
We tried 400 milligrams.
Yes, absolutely. So I think if you want to give it 400 milligrams, because I think that has not shown increased side effects or any other thing. And in fact, I think if you remember correctly, one study using 200 milligram did not show much benefit compared to 400 milligram.
No, sir, it was 100 milligram versus 200 milligrams, and it was in children, and 200 milligrams showed effect, whereas 100 didn't.
Okay, so for adults, I think 400 milligram. For children, I think if that answers Dr. Nayush, that was your question. Yes, melatonin has an effect, and in fact, combining it, there are a few studies combining with the standard preventives like amitriptyline helps in migraine. And of course, melatonin is very useful in cluster headache because that actually modulates the sleep-awake cycle and the hypothalamic activation. Another thing is this, that what about this role? You have not actually covered that. What would be their role in specific situations like patients with pregnancy? So what is the scenario there? I mean, would you like to recommend that? And I would like to ask these questions to both Sumit as well as Girish. First you answer, then we can talk about this.
Sir, I would say that vitamins, at least, particularly the water-soluble ones, they can definitely be tried in, and they are given. They're taken over the counter also in pregnancy with hardly any, I mean, no side effects practically. Vitamin D.
So they can be an alternative to the standard conventional therapy during pregnancy.
Definitely.
Sumit, what's your take on that?
Sir, whatever we say would only be conjectural. Let us be very clear on this.
Correct.
There are hardly any studies of significant numbers in the recent past on actual drugs which work on migraine. There would be even lesser drugs in form of nutraceuticals which have been tried in migraine. As it is in pregnancy, migraine would be present as a significant problem in about 1/3 of pregnancies. About 2/3 of them would not have headaches or would be markedly improved. So whatever we would be saying would be conjectural. But yes, amongst the available drugs which we can try in pregnancy would be amitriptyline in low dosage, very low doses of beta blockers with a very close follow-up of patients in terms of intrauterine growth retardation and post-delivery hypoxia. So it makes sense, even if there is no evidence, to try nutraceuticals in these patients. It might not do any harm if it doesn't do any benefit. And also it is important to understand that about 40% of patients with migraine, any trial would have a very, very significant placebo effect. And that would be very high in terms of pain because there is nothing evident externally in patients with migraine. So these are very, very conjectural statements.
I take your point, but as a general practitioner, I think if they want
to know, it makes sense to give them. It makes
Yeah.
sense to give them.
It makes sense to give them because you see that, most of the randomized control trials would actually exclude patients with pregnancy in the trials because that is the standard exclusion criteria.
Exactly. So that's what I was trying to say.
It comes as a, kind of it is first proven in a normal population and then more probably somebody would do. But of course, magnesium has got a long history of usage during pregnancy, during eclampsia and things like that. So I think magnesium can be safely given, and if it's showing benefit in otherwise patient population, so it would in a pregnant patient as well. And I think riboflavin also would be harmless. And vitamin D again is needed for fetal growth and other factors. So if the patient is deficient, then that can also be, given without much concern. And Dr. Girish, your take on that?
Sir, some 3 things I want to tell, sir. Riboflavin I use very commonly, sir. And surprisingly, 200 milligram in adults, it is giving very good results. Okay. And I'm following them with headache diary also. So it has a very good effect. That's what my observation. As per the pregnancy, sir, majority of the patient, after explaining the risks and benefit and the presence of the evidences, unless evidence is there, sir, they will not take. That's what my experience with the nutraceuticals also. And as you are suggesting, this magnesium, even if I tell, sir, they will be hesitant. They will tell, sir, we will see, we'll take paracetamol, and after 3rd month, we will come back. Like that, they will tell, sir. So I have practically no experience of using them during the first 3 months of pregnancy. And as Dr. Sumit was telling, sir, I have used amitriptyline rather than nutraceuticals.
No, that is true. That is absolutely true. That, I think that the first message should go that, you should use less and less number of drugs during pregnancy if the patient requires it, right?
Yes.
Because no drug has got a, quality evidence to support its use, right?
Yes, sir. Yes, sir.
Right. That is one thing. But among the lot, if the patient keeps on having severe migraine attacks during pregnancy, which are disabling, then what to give? In that list, probably this will come that okay, that these are the options that we have, and they will be less theoretically at least less deleterious compared to say something like topiramate or propranolol or So low dose amitriptyline, low dose propranolol are also good. We have been giving it. I have been giving it for a long time. But generally, first we have to have a heart-to-heart talk with the patient. They should understand the risk and versus the benefit. Yes. That is very important. And what is the dose you recommend, Dr. Bhargavi, for vitamin D3?
So vitamin D also, we don't have a dosage schedule. Of course, vitamin B2, riboflavin, we still do know, but vitamin D, the way we correct deficiencies, I think that is the way we should. Despite
there are some recent data. I mean, there is a recent meta-analysis which has shown that actually that if you use to the tune of about 2,000 to 4,000 international units, that is 50 micrograms to 100 micrograms daily. That is a good enough dose for prophylaxis for migraine and other painful conditions as well. So that might be one recommendation. Now we come to the most interesting question, and I think that is a very interesting question. And I'll start with Dr. Sumit. Dr. Sumit, what is the role of iron deficiency in migraine?
I wish it was possible to answer this question. We hardly have evidence of any drug for migraine because it's not considered as an important disease. That's the most unfortunate part. You and me both know this, that there are thousands of articles on multiple sclerosis. There are thousands of articles on stroke. There are thousands of articles on diabetes, hypertension, and migraine is almost more prevalent than most of these disorders. Like we look at flunarizine, there are hardly important articles which have adequate numbers and have a robust evidence supporting flunarizine. And you can understand that even American Academy of Neurology does not have flunarizine as a recommendation, regardless of it being supported by some articles. So iron deficiency would definitely list somewhere as a
Yes.
causative agent for
I
migraine.
think, yeah, I think the person who has asked, I think Dr. Vadiraj, he has asked this question because I think, there have been some recent papers, especially from the Iranian group, about the role association between the iron deficiency and migraine. But as you say, that in developing world, iron deficiency is rampant and migraine is also very common. At least to find out that association is not difficult if you want, one tries to. So how much sense? But in clinical practice, I have seen some patients of mine, especially the women in childbearing age, especially those with a menstrual migraine, are having iron deficiency. So I would like to know about Girish opinion on this. Girish.
Sir, not much experience, sir, because we have never tested that iron deficiency state in women, sir. Majority we will get one hemogram and
Okay.
homocysteine and RFT, LFT maximum, sir, and one ECG. So this
Can I
part
make a
have
statement,
missed.
sir?
Right. Yes, yes.
So what I do is that I have almost included my list of investigations in patients with migraine. I mean, blood investigations. I have included iron studies in that series of investigations.
Okay.
So there is
Right.
no harm in, getting a vitamin D tested, vitamin B12 tested, and serum iron tested, and then give them these supplements. Vitamin D deficiency might or might not cause any problem, but vitamin D excess will definitely cause problems in terms of idiopathic intracranial hypertension and worsening of headaches. So what I do is I have included serum iron studies as a part of my investigation protocol for all disorders in neurology.
Mhm. Okay.
Because it's so
Dr.
rampant,
Bhargavi?
it might not have any loss.
Correct.
Maybe it might have some benefits.
It might have some benefit. We need trials, good trials about. Dr. Bhargavi, did you find anything on iron? Did you check for the iron in your?
I did not specifically check for iron, but I have not found in the pathophysiology about iron deficiency being prominently featured.
No, but there is an emerging literature which is coming up now, especially from this, as I said, Turkey,
Iranian
Iran,
studies. Yes,
Iranian group. And in fact, there is one particular type of migraine which has been described with iron deficiency, which is called as a late menstrual migraine. Most of the migraine which are precipitated by during menstruation is an early phase of menstrual cycle, right? At the beginning of the menstrual cycle. But there is one variety which has been, I think, published a few years back from US about a late menstrual migraine with iron deficiency anemia. So I think we have to keep a watch on this and find out that whether there is a kind of association, because iron deficiency anemia is also rampant in our country, and
yes,
we need to look at that from that. So I think we'll take up the questions further on, and I now request Dr. Sumit to present the most important talk, the prevention part, which is besides the nutraceuticals, the other conventional and the newer treatment options in migraine. Before that, can I have a slide for introduction? Dr. Bhargavi, can you, yeah, right. So as you know, Sumit is the director of Artemis Hospital, Gudgaon, for this neurology section. Neurology, they have got their entire neurology unit together called AIIMS, and he has been formerly in additional director of Medanta, and then he was earlier in All India Institute, and he has got a lot of interest in multiple areas in neurology, including headache and movement disorders in particular. And he is currently the member of the EC of Indian Academy of Neurology, and he is a close collaborator with me on many of our headache, work and headache conference, and also together we have, formed the Headache Society of India. So, Dr. Sumit, may I request you to kindly load your presentation and start the proceeding.
Thanks, Dr. Debashish. Is my presentation visible?
Yes, kindly make it,
Yes.
yeah, full screen, yes.
Am I audible also?
Yes.
Right. Thanks, Dr. Debashish. So We have a very, very interesting topic here of conventional migraine preventives. Where do we stand today? And this topic has actually probably risen from the ashes of new treatments options which are available. So I would like to say that primary headaches have a different scenario depending upon whom the patient is seeing. If it's a general type of it's a physician, then tension type headache might be the commonest. To a neurologist, migraine might be the commonest, but to a headache specialist, it's the chronic daily headache which is the most troublesome. There would be a list of questions which one would ask to these patients with all types of headaches to come to a conclusion whether they are actually suffering from migraine or any other disorder. And I think this is the basic of headache neurology, to understand and come to a conclusion about what the patient is suffering and what treatment does he want or does he deserve. For a patient whose diagnosis has already been made about that he's suffering from migraine, the treatment would probably be preventive, most importantly, if required. Treatment for an acute attack of migraine if the headaches are not very frequent. And then non-pharmacological and education of the patient in terms of explaining to him about his disease. Now, this education part, I think, is absolutely the most important part in migraine management. The non-pharmacological and the nutraceuticals aspect have been discussed partly. The acute treatment is not a point of discussion in this particular presentation. So I would be focusing on the preventive treatment. So before we come to the preventive treatment, I think a very, very important part is to tell these patients about understanding the triggers which cause migraine in that particular patient. So about explanation in terms of the triggers might be a very, very important educational tool for all these patients. So maintaining a headache diary and understanding what is causing headaches in that particular patient is worthwhile. Pharmacotherapy is a second tool which comes after explaining to them about their disorder and the management options. So we have to understand and we have to explain the patient that his headache is actually not because of his drugs or because of analgesic overuse if the headache is chronic. And of course, ask the patient to observe for the trigger factors and avoid them if possible. Symptomatic treatment would be required in some patients, and prophylaxis and supportive treatment would be the keystone for management. Now, these prophylactics, they work very, very well if they're taken. If the patient does not take a prophylactic, then obviously it's not going to work. And if he stops the treatment in between, or if he chooses to discontinue the treatment for prophylaxis, then obviously it is not going to work. And therefore, compliance is probably the key issue. And compliance definitely depends upon how effective the drug is, how frequently the patient has to take this medicine, what are the side effects involved, and what is the cost involved in this treatment. So when do we consider giving any prophylactic at all in a patient with migraine? So these things have been evolving over a period of time. Previously, it was only the number of headache days. Then it was the severity of headache and the number of headache days. But now, over a period of time, most consensus aspects across the world state that if the migraine is significantly interfering with the patient's daily activity despite acute treatment, if the frequency of attacks is higher than what is likely to cause medication overuse headache. So I'm not putting 2 months, 2 per month or 3 per month criteria or a 4 per month criteria. Any headache where acute medications are either ineffective, are contraindicated, or are having troublesome adverse effects, or are going to cause overuse headache. If the patient prefers to take a prophylaxis, and patients who have uncommon migraine conditions like hemiplegic migraine, basilar migraine, migraine with prolonged aura, and migrainous infarction. So we always start with the low dose and increase it gradually. We need adequate trial of about 2 months before we label that a particular drug is not working. Of course, in between, if you don't give an adequate drug and it doesn't work, the patient is definitely in India going to seek a second opinion. So you are actually going to lose a patient if that medicine which you are going to give is not working. We should avoid the medication overuse and the interfering medication. And we should taper and stop the medication if the headaches are very well under control. Most of the drugs are contraindicated in pregnancy, particularly like topiramate, high doses of beta blockers, divalproex, sodium, gabapentin. So you should tell these patients about having an adequate birth control usage and to report to you in case they become pregnant. Never change a drug after each attack. Consider the comorbid conditions. You should be observant for drug interaction. Use monotherapy as far as possible. Educate the patient about compliance. Now, I would divide the treatments which are available as conventional and the newer ones. Amongst the newer ones, the nutraceuticals like riboflavin, magnesium, coenzyme Q, feverfew, and buttercup have already been covered. Botulinum toxin is a drug which has been proven to be ineffective in episodic migraine. It is a drug which is for chronic migraine, and I think that it should be left out of this particular discussion. So amongst the ones which we need to discuss between the conventional and the newer ones would be conventional drugs and the anti-CGRP antibodies. So amongst the conventional drugs which are available to us, beta blockers, calcium channel antagonists like flunarizine, serotonin antagonists like various types of selective serotonin reuptake inhibitors and serotonin and norepinephrine reuptake inhibitors, neuromodulators like topiramate and divalproex, various types of antidepressants and non-steroidals would be the drugs which would be a point of discussion, but in this type of presentation. Now, if you look at beta blockers, it has been approved by the FDA for, I think, a donkey number of years. The dosage which has been tried is 60 to 240 milligrams of propranolol and 10 to 30 milligrams of timolol. There is limited evidence which exists today in terms of the usage of nadolol, atenolol, and metoprolol. So they must be reserved drugs if beta blockers are the only options available, and propranolol is either contraindicated because it's not to be given in young patients who have, particularly males, because it can cause erectile dysfunction, or patients with bronchial asthma, or patients with diabetes in terms of unmasking of the effects of hypoglycemia. Now, in terms of the usage of propranolol in, sorry, just a moment. So this is a meta-analytic review in which 2,403 patients who were tried with up to 160 milligrams of propranolol per day were evaluated in terms of its usage in terms of prophylaxis for migraine. And if I would like to come to a conclusion, then the results estimate that on an average, propranolol yielded a 44% reduction in migraine activity when daily headache recordings were used to assess treatment outcome, and a 65% reduction in migraine activity when less conservative measures were used. Now, it is very, very interesting to observe that despite so many numbers and so many trials with propranolol, over a period of time, even the definition of migraine has changed. So episodic migraine is further subdivided into low frequency episodic migraine and high frequency episodic migraine. And over a period of time, a phenomenon of chronic migraine has also evolved. So actually what these drugs have evaluated might be migraine, might be episodic migraine, might be chronic migraine. So that is where most of these trials which have evaluated propranolol might not hold suit in the present scenario where the evidence-based medicine has evolved in the present era. Other drugs, flunarizine, it's a fantastic drug in dosage of 5 to 10 milligrams. Higher doses might be more effective. In various trials, it has been found to be as effective as propranolol. It is a calcium channel blocker, so it causes vasodilatation and smooth muscle relaxation of the small vessel walls. If you look at the number of trials, there are at least 16 trials as compared to about 40 trials for propranolol. It's a very, very commonly used drug in India. It has been found to be definitely superior to placebo in most of these trials. It might be the drug of choice in patients with childhood migraine, in patients with complicated migraine, and individuals who are non-depressed and are thin individuals. Because it can cause worsening of a pre-existing depression, it can cause depression, and it might cause extrapyramidal disorders in elderly individuals. If you look at the evidence which is supporting flunarizine, then there have been several trials, and this is a meta-analysis where 9 studies were obtained, of which only 4 met the inclusion criteria, and it was found that somnolence was the most frequent side effects. The total number of trials were high, but the total number of patients included in each trials were less, and the final conclusion in this review was that flunarizine might be a very good drug in terms of reducing the frequency of migraine attacks. Now you can understand that these were the reviews in neurology in 2003, and the definition of chronic migraine at that time was actually evolving. So we don't really know how many of these patients were episodic migraineurs and how many of these were chronic migraineurs, because episodic and chronic migraine might be a completely different level of pathophysiology involved. Then we look at the anti-epileptic drugs. In terms of anti-epileptic drugs being taken as a group, there are 15 papers where more than 2,000 patients have been evaluated, in which there are 14 trials which have compared anti-epileptic drugs with placebo. Most commonly drug tried has been divalproex sodium, unfortunately. Then there are 3 trials with topiramate, some with sodium valproate, gabapentin, carbamazepine, clonazepam. Of these drugs, a head-to-head comparison between 2 components is not usually available. There is only 1 trial where sodium valproate has been compared with flunarizine, and 1 trial where divalproex sodium has been compared with propranolol. So if you look at the dosage which are required for these patients with migraine, then in terms of requirement of dosage in epilepsy, the dosage which is required in migraine is markedly less. So divalproex as low as 500 milligrams, gabapentin as low as 1200 milligrams, lamotrigine 200 milligrams, topiramate as low as 50 milligrams, and sodium valproate as low as 800 milligrams might be effective in terms of these trials. As a group, it was found that it was far superior to placebos. It was better than active comparators as well. And levetiracetam was not included in these trials, but over a period of time, we have observed that levetiracetam has been evaluated in 3 small trials, where it has been found to be almost as effective as other active anti-epileptics, because there are no head-on trials, so we can't compare that. But it is definitely much effective as compared to placebos, and it can be used as a reserve drugs in resistant cases. Now, amongst these drugs, because divalproex and topiramate have the largest number of patients enrolled, therefore they require a special mention. So divalproex extended release has got 4 large trials. There are no randomized trials which have compared this drug to the conventional prophylactic agents. There's only one trial where it has been compared with propranolol and has been found to be equally effective. Sodium valproate has been compared with flunarizine, and there was no significant difference observed. Topiramate is a drug which is a very, very favorite drug for me in terms of migraine management in non-depressed obese individuals who do not have any cognitive impairment. It's a calcium channel blocker, it's a sodium channel blocker, it's an AMPA kinase receptor blocker, and a GABA receptor analog, apart from weak carbonic anhydrase activity. Sorry, weak carbonic anhydrase inhibitor activity. It's a broad spectrum anti-epileptic drug, and it has been, I would not say recent, but it has been there for at least 10 years, because I conducted a trial on this drug when I was in AIIMS. If you look at the recent drugs which have been incorporated in the management of migraine, that it would probably be labeled as the drug which largest numbers of trials which support its usage. The dosage is 50 to 200 milligrams. We all know the side effects. One has to be very careful in patients because it can cause an acute angle closure glaucoma in some patients. It can cause paresthesia because of its carbonic anhydrase inhibitor activity. It can cause weight loss, which is actually a good thing in obese individuals. And it can cause nephrolithiasis. So one should be careful in selecting these patients, and we should ask all these questions about glaucoma and nephrolithiasis in all these individuals. We have a published study on this, which we call as the LOTOLAMP study, where low doses of topiramate, as little as 50 milligrams, was far superior to lamotrigine as a comparator for migraine prophylaxis. Now, if we look at the number of patients who have been recruited, then now in terms of topiramate, there are only 3 studies in which more than 500 patients have been evaluated, as compared to the entire 40 studies where only 55 to 60 patients in the propranolol group, and about similar number of patients in flunarizine group have been evaluated if we look at the intention to treat analysis on all these patients. Amitriptyline is a drug which probably might be a little more used, but again, these trials are not intention to treat analysis based, and they are not adequately powered studies. So I'm going to leave these studies out in terms of topiramate. What I would like to say that all the trials which have evaluated topiramate, the primary endpoints revealed that there was a statistically significant improvement in mean migraine intensity and frequency in the treatment group, and a statistically significant higher responder rate in treatment group as compared to the placebo. They say that the side effects were similar, but I think it is not possible, because topiramate side effects are so unique that it is very, very difficult for any person to not report them. This is the study which we did, and it is a published one. Now, the newer drugs on the block are anti-CGRP molecules, and that is where probably the most important comparison between the two groups in terms of conventional migraine management and new migraine management would evolve. So there are 2 types of molecules, one which act on the CGRP receptors and the ones which act on the CGRP molecule. So these are all monoclonal antibodies. The ones which act on the ligands are actinizumab, galcanezumab, flumenzumab, and the ones which act on the receptors are anarinumab. The ones which are available in India are anarinumab. We have conducted finished trials on galcanezumab, and we expect this drug to be available in India by the end of this year. So now these drugs are probably very, very effective in the management of migraine, and they probably are targeted drugs for the management of migraine. Because if you look at the pathophysiology, then obviously, if we knew the pathophysiology, then so many trials would not have been conducted. Whenever there is a disease where more than 2 or 3 theories exist for its causation, probably none of these theories are correct. But yes, if we look at the levels of CGRP in the jugular venous samples of patients during an episode of migraine, then they are found to be extremely high. The CSF levels in patients who have an episode of migraine at the time of headache have found to be high. And it has been found that CGRP might be a molecule which might be inherent to the causation of migraine, and probably that is where these drugs they come into play. So the ones which are available today are these ones, and there are almost several trials which have evaluated their role in migraine prophylactics. So this was a meta-analysis of all the anti-CGRP molecules, and this was published in the British Medical Journal. And this is a very recent study where efficacy and safety of CGRP blocking monoclonal antibodies for the preventive treatment of episodic migraine was evaluated. Now, these are very high quality randomized controlled trials where more than 4,402 patients were evaluated, and they were compared to a placebo group. So it was found that CGRP MAP therapy might cause a significant reduction in terms of monthly migraine days, definite reduction in acute migraine specific medication days. The 50% responder rate was much higher in patients who received anti-CGRP molecules as compared to placebos. The adverse events were similar as compared to the placebos. And if you look at the anti-CGRP molecules as a group, then all 4 of them were found to have similar efficacy results. Now, if you look at the ones which are available today and the ones which have been available recently, then the ones which are available, the only point of concern is that patients do not stick to the drugs which are available, partly because of the side effects, partly because of the lack of efficacy, and partly because of the frequency of administration. So if we have a drug which might be used once in a month to a drug which is to be taken twice a day, then obviously there might be an inclination for patients to be more inclined towards using a once-a-month injection as compared to a daily medication. But another point of discussion might be actually, are these drugs effective as much as they say as compared to the conventional prophylactic agents? So the current recommendations are that any adult with a diagnosis of migraine with or without aura who has an inability to tolerate or has an inadequate response to a 6-week trial of more than 2 drugs which have been recommended as oral therapies and the migraine associated disability is higher are the candidates for anti-CGRP molecules. If you look at the ones which are available in terms of like arenumab, topiramate, and onabotulinum toxin A, then we see that the number of patients needed to treat are lower in terms of the anti-CGRP molecules as compared to the conventional drugs, and the number needed to harm are very high in the anti-CGRP molecule arm as compared to the conventional treatment arm. This is a very poorly conducted study which is industry sponsored, in which there was a head-to-head comparison of arenumab against topiramate, and in this study the patients were designed to achieve or receive arenumab versus oral topiramate, in which 777 patients were evaluated. Interesting point was that in this study, it was the side effects of the primary drug which were primary endpoints in terms of treatment discontinuation due to adverse events of topiramate as compared to the secondary objectives, which was an at least 50% reduction of monthly migraine days. Now, if I were to conduct a study, I would like the patient to be more, sort of responsive to the treatment rather than discontinuation of the treatment because of the side effects. But anyway, it is the industry sponsored study, and this is the only study which is available in terms of comparison between the newest molecule available and the conventional treatments available. Of course, the trial was in favor of anti-CGRP molecules. And if we did a post hoc analysis in terms of a sensitivity evaluation, then in a hypothetical scenario, then it was also that probably most patients would like to continue on arenumab as compared to topiramate. The patient-related outcome results were also in favor of arenumab. It was a safe drug, and we all know that actually it is beyond question that the safety profile of the anti-CGRP molecules is higher as compared to most conventional anti-migraine drugs, because the only side effects which have been evaluated and produced in terms of both randomized trials and long-term open label studies and market survey analysis have been only mild degree of constipation because of the anti-CGRP effect of these drugs on the gut. So there is no doubt that the efficacy of these drugs might be a little questionable, but the side effect profile of these drugs is extremely safe. So if you look at a final statement, then probably old is not gold, but latest is not the best. The anti-CGRP drugs, which are the new kids on the block, have potential advantages over the conventional treatments. The pharmacoeconomic studies are the ones which are required to evaluate the economic impact of these drugs versus the conventional drugs. The overall direct and indirect costs related to untreated migraine and to migraine treated with other available preventive therapies, and also the efficacy and side effect profile of these drugs, the newer ones compared to the conventional ones, need to be evaluated. There's no doubt that these drugs are costly. Adalimumab costs about 21,000 rupees on a monthly basis to these patients. But at the same time, coenzyme Q also causes about 6,000 rupees on a monthly basis. So it is very important to understand that because of the high cost of these therapies, it is essential to implement all possible strategies to optimize their effectiveness by optimization of the patient selection for these newer drugs as compared to the conventional ones. So thank you very much, and I bring you greetings from Team Agrim, which is the one which you see on your screens. Thank you very much.
Thank you, Sumit, for a very comprehensive talk on the available conventional migraine preventive drugs and their comparison to the newly evolving paradigm of anti-CGRP monoclonal antibodies, which are sweeping the migraine world right now. And as you have rightly said, that we need to wait and see. And although they offer a substantial benefit over the conventional drugs, but the cost is a limiting factor. And even then, most of the guidelines are recommending these drugs after the failure of at least 2 conventional drugs being tried for migraine patients. So I think with that, I think we'll take up some questions on that. So first thing is there's that question to Sumit only, that so among the conventional agents, how do you prioritize? How do you select the agent? Which one to give? Can you shed on light on that?
Sir, I think this is one answer which is common to all of us. We decide according to the patient profile and the side effect profile of a drug. So in a bulky individual who's not depressed, topiramate might be a very good option if he is not a child, because it's going to cause weight loss, and that might take care of the psychological component of weight gain. In young ladies who are non-depressed, a drug which causes weight loss in them might be a cause of relaxation and might take care of the migraine itself. Propranolol is not to be given for individuals who are sexually active or young adult males because it can cause erectile dysfunction. It's not to be given in diabetics and asthmatics. Divalproex would cause polycystic ovarian disease. It might cause alopecia, hepatic dysfunction, and weight gain in young ladies. So they would be more depressed because of their period abnormalities and weight gain. So amitriptyline is a very good drug for depressed individuals who are not obese. So one has to be, I think, creative and innovative in terms of selection of patients, not because of their efficacy, because there are no drugs which have been compared head to head in significant numbers, where I can say divalproex is far superior to topiramate, or I can say that topiramate is far superior to propranolol, or propranolol is definitely inferior to flunarizine. So one has to be innovative and select the drugs which are sort of customized to one particular patient in terms of their effects and the side effects profile.
Okay, that's good. So that means, in short, that you have to use the therapeutic limitations and the opportunities and decide on the
Exactly.
best possible drug that is suited for that individual.
Exactly, sir.
Okay, right. Girish, the question for you is this, how long you should treat? This question keeps on recurring in every forum. How long should you treat the patients with anti-migraine drugs as a preventive?
Sir, I usually treat 3 to 6 months, sir, and then try to reduce the dose and taper off next 1 to 3 months, sir. And I will tell them that this headache is a common symptom, and there are multiple types of headaches, and you keep a watch, and if you feel anything there, you please come back. But I will try to taper it off in almost all patients after 6 months, sir.
Okay, right. So I think 6 months is a reasonable time, and there is at least one randomized trial to show by Professor Diner, that 6 months is a good enough time to have the effect. But of course, there will be migraine patients who might come back again with once the drug is tapered, and then you will have to reinstitute the treatment. And of course, chronic migraine is a different ballgame altogether. There you have to continue for a long period of time.
Yes.
And in tertiary care centers where you see difficult patients, there I think you need to continue for a longer duration of time.
Yes.
But in general practice, 6 months is a reasonable time. Okay. So, Dr. Sumit, any thought on the timing? How much time? Is there anything
No,
you
sir,
want to add?
you're absolutely right, sir. I tell that to my patients that your migraine is the deciding factor, how long you require the medication. I will try to stop the medicines after 6 months. And if you're lucky, your migraine might not trouble you any further. And if it troubles you again, then I
Come
will
back
give
to
it
me.
as long as the migraine is there.
Okay, right. So, Dr. Bhargavi, this is a question for you. What is the role of combination of these nutraceuticals? Now there are some preparations available in India which combines these nutraceuticals. So, what is your take on that combination treatment?
So, majority of the studies, at least many of the studies, I would say, almost as many as we have seen for single agents being used as interventional drugs, are combinations. So I would say, and combinations have given good results in most cases. In most of the studies, they have combined antioxidants like coenzyme Q with botanicals like feverfew and riboflavin, and even there is a study with vitamin D and simvastatin. So combinations have given results. And although it is difficult to make out which one is the active agent or which one has given the benefit, if the adverse effects are not there with the combinations, they may be less because fewer. It's possible that we can get away with lower dosages at times. So maybe adverse effects are also few, although we won't be able to attribute it to this agent or that. So.
Okay, so so given a situation like this, now since these drugs combination nutraceuticals are available in India, earlier it was not because they were non-specific dosage and this thing. So they are now available. So Girish, how frequently do you use that? And again, Sumit, how frequently do you use the combination nutraceuticals for migraine prevention? Girish.
Sir, very less in combination, sir. More of a single agent. And I would, in other groups also, sir, first I will try to use a single agent. If not helpful, then only I will add the 2 agents.
Sumit?
So you are well aware of the situation which we are in. So the patients who come to us are not the routine headache patients. They already have a pile of investigations and a pile of prescriptions available to them. So in our practice, it might be a little different. But yes, I agree. In general practice, a single drug might be a better option as compared to comparison. Many times, if there is a new patient who comes up with migraine, I say that there are practically no side effects of this drug. So you can try it. If it works out well, then you might be very, very happy because it does not have any side effects, and it's not actually a medication. It is a nutraceutical. So many patients feel happy. So I
Correct.
actually use them as a monotherapy in new onset migraine patients who are young and who are those Google searching type of patients.
Correct.
And they're very, very happy because you're actually giving them no drug. You're giving them a nutraceutical.
Correct.
And all these patients with any types of painful conditions, including migraine, have about 40% placebo effect. So I'm not really sure whether they work or not, but I would definitely give them a trial, not only as a combination, I give them as a monotherapy in these patients.
Right. So yeah, I think my take would be almost similar, but only thing is this, that, it depends. Like, I generally would like to have a kind of an start with a conventional medication. And usually if the patient does not respond, then I would like to, give an add-on, this kind of. As a monotherapy, I have not used much, only in situations where, as you said, the patient is very Google savvy and, has Googleitis. So they are very, very afraid of taking
Exactly, sir.
medicines, but they still suffer. So in that case, in order to convince them, I do give them as monotherapy. So that is the situation. And I think that holds true for most of the private practitioners. Of course, in our workup, we actually use many other things like, botulinum toxin, we use occipital nerve blocks. So next question is that what is the role of biobehavioral therapies in prevention of migraine?
Can I
Sumit.
answer that, sir?
Yeah.
So we did a randomized trial for autogenic relaxation techniques. So we had Dr. Usha in AIIMS, where we randomized patients to receive 20 minutes of autogenic relaxation technique versus conventional treatment. And we found that it definitely works in many of these patients. So it might be a worthwhile technique because it is one thing which might be effective, which is completely free and has zero side effects. So I think it should be tried. And I actually advise most of my patients to go in for, because you also know, and we all know that many of these patients are actually type A personalities. And type A personalities have a higher incidence of migraine as compared to other types of personalities. So I think a neurobehavioral modulation and an explanation of the condition is worthwhile trying in all these patients.
Girish?
Sir, I want to just show this paper, sir. Recently, we have worked on this. And sir, you are able to see, sir?
Yes.
Sir, this what Dr. Sumit is telling. I agree, sir. In chronic daily headaches, where predominantly majority of them were migraines, we have this quantitative and qualitative interviews, and we had various types of biological, psychosocial, and environmental social culture, sir. And this framework we have done now. So next step, we are planning to do the treatment with respect to these things. I think it is a very encouraging thing in this chronic daily headache group patients.
Correct. So
we have tried this on both tension type headaches. I'm not really sure because this study was done in 2004 when we did this with Dr. Usha Kiran. So I'm not really sure whether how many of these patients were chronic migraines and how many of these were chronic tension type headaches, because at that time the definitions were evolved.
Yes.
Correct. So I think I take your point, that obviously this does help, but unfortunately in India, to get these facilities at a general level, at a journalist level or at even an MD level, there are not many clinics who are offering this biobehavioral therapies and not many qualified persons. That's, I think, is a hindrance. And basically, if patients land up in a psychiatrist or psychoanalyst doorstep, then it actually becomes counterproductive from my point of view. So I think we need to actually also make this thing aware, make people aware, and we should actually promote this, because that is very, very important. And of course, incorporation of yoga. There is one paper from recently from AIIMS also, Rohit published, where the yoga was found to be effective. So I think the answer to that question is that yes, biobehavioral therapies are very important. And one component of biobehavioral therapy is, of course, what Sumit has said in this puzzle is the patient education. So I think, if we leave this meeting with this kind of idea that patient education is probably one of the most important factor in migraine management. So I think that will be a great achievement. Your comments on that, three of you, patient education. And how do you want to do that patient education when the patient comes to your clinic? Sumit.
Okay. I think the 6 to 9 months of treatment with any type of pharmaceutical intervention is much more costlier and much less effective than those 6 minutes which you spend with the patient and explain to them that this is one disease which is a part of your life and will stay a part of your life as long as it decides to stay with you. So only migraine will decide when it is going to leave you. There is no medicine in the world which can cure you. If you can take the treatment of thyroid insufficiency lifelong, if you can take treatment of diabetes lifelong, if you can take treatment of hypertension lifelong, why you're so much troubled because of innocuous disease in terms of its dangerousness, I must say, in your life, then why can't you take the treatment of migraine as long as it stays in your life? In the meanwhile, you try to change your lifestyle. You try to be more healthier in your lifestyle. You try to be more managing your triggers. And then your migraine, if it is reduced to once in a month or twice in a month, then I'm extremely happy and I'll be more than happy to stop your medicines. So if the patients are given that time to explain, which unfortunately most of these patients don't receive, then probably migraine would be a better managed disease for most of these patients.
Correct. Girish.
Sir, what I feel in addition, sir, if plain migraine is there, education, avoiding the triggers, better treatment with prophylactic agents and duration, sir, will take care. And aura, and if other risk factor and comorbidities are there, sir, I think we should explain to the patient party about the aura and why it comes and why it is there. Otherwise, sometimes they become too much afraid, especially visual auras, if they are occurring without headache in some patients, that we should explain, sir. And the duration of the treatment, it will become only successful if we choose a medicine with the least side effects for that given particular patient, and he understands why we are giving these medicines for this duration of the treatment, sir. So these are my additional things to Dr.
Yeah.
Sumit.
So in biobehavioral parlance, there is a term called locus of control.
Yes.
So once the patient has the locus of control and thinks that he or she can, by understanding the disease, can control his or her migraine, then it goes a long way in having a very effective outcome, good outcome of the treatment, whatever we offer. Dr. Bhargavi, your thoughts on that? Dr. Bhargavi, are you there?
I'm here, sir.
So what do you think about
What
education, patient education?
In patient education, sir, first thing I think we should go about saying is that the effect of drugs, the preventive medications would be only limited to say 30 to 50% by way of frequency, by way of severity, and the disease may not go away, as Sumit sir said, and it may stay for many years. That is one thing that, and that they probably would not need management for a long time. We may taper it off or stop the medication as and when it is not required. The second thing is, sir, long-term patients, they ask for repeated neuroimaging. They come to us with MRIs and CT scans done already. So I think we need to tell the patients, if we are sure that the diagnosis is migraine and there is no change in character and there is no difference with respect to his or her earlier symptoms, then repeated neuroimaging is not probably going to help, and which is something that I feel patients are very jittery about, why this headache is continuing, and that we should keep doing another MRI every few years maybe. So, which is a waste of resources as well as.
Yes, I think that's a very good point that you have brought out.
That we need to educate them about.
Yes. Yes, I think that's a very good point from general practice point of view, because there is a tendency to get repeated imaging. Now there are some data available on that front, and in fact, if the patient wants to be sure that he or she is not having say brain tumor or any serious anomaly in the brain, a first-time neuroimaging can be done, and that reassures the patient. But unfortunately, that reassurance lasts for only short time. The studies have shown that it lasts for about a few months, and then again, if the headache continues, then the patient again comes back and says, "Oh, doctor, please look at it again." So basically, the answer to that would be to have a talk, to have this education. That is the answer. If you are able to convince your patient and another thing is this, that although we are saying that 50% responder rate in 50% of the patients, right? So that is in general a general statement, but in a given patient, that might produce a dramatic change in his quality of life. If you actually treat the patients, if, as Dr. Sumit is saying, that if the attack frequency is reduced from 10 per month to 2 per month, the dramatic improvement happens in the quality of life, especially for the person who are working, working people, right? So that actually is the point which you should emphasize, that although it will not go away because it is genetically driven, your migraine is not going to go away, but it is going to dramatically alter your quality of life by taking this medication, then the patients will stick. And you can do yourselves a bit, by improving that, by avoiding triggers, by doing this, biobehavioral therapies in the form of yoga, in terms of mindfulness, meditation, and regularity of lifestyle. All these things will go a long way in reducing the burden and the improvement in the quality of life. I think that education is very, very important, and we should not be, kind of shy away from that. And for the people who are in the audience, the general practitioners, they should remember this, and I think that will be very, very helpful for them. Now, I think the last question is the most interesting one, and I think very pertinent one, and that is that what is the situation post-COVID? What are post-COVID headaches, and what is your impression about this? Because the pandemic is still raging, and I think another wave is going to come in, say, about a few months down the line. So what are your takes on that? Girish.
Sir, two things, sir. Literature-wise and personal experience, sir. There are two group of studies, sir. One group telling that because the various triggers factors for the migraines have come down, probably migraines are better. Like that, one group of studies are telling. And another group is telling that probably because of unavailability of the various treatment aspect, this headache things have worsened. My personal things are, there are two types of headaches I'm seeing. One is this mask. Because of the mask, many people are coming with headache, which is very peculiar. 4 hours after they wear the mask, they will develop a headache in and around the eyes, and they will have a severe problem in that. And sir, another group, well-established, controlled migraine patients who are off the medicine, they have come back after this third wave with restarting of their migraines. These are 3 observations I've seen.
Correct, absolutely. You are dot on that, and I think that if you must be aware of our publication on the in ACTA, in which we did a national sample survey, and we found that actually the migraine worsened in India, for most of the patients. So, Sumit, your take.
I agree with you, sir, completely. I personally feel that the number of patients who have come to me with worsening of their headaches during COVID is much higher than new patients who have a new onset migraine or a migraine referral. I agree with you, sir, completely.
And any patient who come after vaccination, say COVID vaccination as a fallout of COVID vaccination with
Frankly speaking, sir, most of them are secondary headaches.
Mhm.
I've not found many patients who have come with a migraine worsening or a new onset migraine after vaccination. But I have seen several patients who are secondary headaches because of venous sinus thrombosis, acute disseminated encephalomyelitis, strokes. So secondary headaches have definitely worsened after vaccination.
Right. Dr. Bhargavi, your take on that?
Sir, actually, I have seen a few patients who have come with new onset fatigue with headache being very prominent post recovery from COVID. And however, they were few in number. I would not be able to comment about the increase in headache because I did not sit in a headache clinic but this I did observe that some patients did come with post-COVID, post-recovery headache and fatigue, which after reassurance, some of them had come with imaging also, neuroimaging also of the brain. So which did not show up anything other than, I mean, we expect nothing in the major in the pathology there, but some treatment had to be initiated in the form of maybe amitriptyline for these kind of patients. Not typically migraine, maybe, but headache, maybe tension type. Maybe stressors contributed to all this.
Yes, I think the stressors have played a large role in accentuating the migraine and the tension type headache post-COVID. But COVID per se, there is a long COVID syndrome in which the fatigue, brain fogging, and sometimes this dull headache that has been complained by some people as a part of a long COVID syndrome. But I don't think we have enough data on that as of now. But definitely that needs to be looked into. And as Girish has said, that one is mask and one new type is the PPE kit induced headache that has been, also been, kind of reported. So, residents who are working with the PPE kit on for 6 hours, 8 hours, they were actually having either an exacerbation of their migraines or they developed a new type of headache, which is akin to, phenotypically similar to migraine. So I think COVID has played its role, and as Dr. Girish showed that we had given some recommendations for how to manage that in our article on that. So I think we have covered most of the questions, and if anything you you want to ask anything or you want to comment on anything, or otherwise at the end I will go a quick fire single liner answer to each of you about 2 or 3 questions, right?
Yes.
Should I go ahead?
Yes, sir.
Sure, sir.
Okay, Girish. So what do you suggest to your patients when you and the doctors to how to start the preventive therapy?
Make sure, sir, diagnosis is correct, and you find out the nature of the patient and the disease and the side effect profile. Start slow and gradually increase, and follow with them with headache diary.
Sumit, somebody says that, okay, this disease is a genetically disease, you will have it lifelong, there is no treatment. What answer will you give to that person?
I agree with them. I would say that yes, it is not a curable disease, but I'll definitely be able to help you. I'll be definitely able to control your headache frequency and intensity over a period of time, but I'll not be able to take it out of your body. It is definitely genetically associated, though not genetically caused.
Bhargavi, if you want to prescribe a nutraceutical either alone or in combination, would you hesitate as a clinician for migraine prevention?
I would not. I would discuss I will discuss the options, and particularly in a new or a young patient who is receptive to try for at least 3 months a nutraceutical first, preferably as a monotherapy. But if necessary, if I find deficiencies as a combination, I would go in for it, as the number of side effects and the side effect profile is definitely better compared to the conventional therapies.
Okay, Girish, Do you think that the migraine education should continue with the physicians as well as the laypersons?
Yes, sir. It should be, sir. It is the most important aspect, sir. And as Bhargavi was telling regarding the nutraceutical, sir, I have very good experience with riboflavin, sir. And young ladies who are, those who are very conscious about the side effect and other things, I will be thinking whether I can start them because of the low side effect profile for them.
Sumit, what do you suggest would be the step forward for continuing medical education in headache for the undergraduates, postgraduates, and the physicians?
Take headache seriously.
Good. So I think very good, short and swift. And I would conclude thereby saying that it is a nice, kind of an update, which through which we try to provide you an overview of the migraine diagnosis, about the the barriers and the challenges that are faced by you, and in general, what are the perspectives from Indian scenario, and also the conventional treatments, the newer treatments, as well as the nutraceuticals for migraine treatment. And I think there is a lot of research going on in the migraine field internationally. And it is important that we actually give importance to it, because you like it or not, you are going to see these headache patients in your clinic day in, day out, right? If you see about 50 patients, at least 10, 12, 15 will be a headache patient. So therefore,
Not in your clinic and my clinic, sir.
and therefore, it makes sense. It makes sense that we actually give importance to it. We diagnose them properly. We treat them properly, because if you treat them properly, they are going to stick to you, and they are going to be with you throughout your life and career. And they will be a good messenger for you, spreading your skills and about your acumen. So thank you very much, all the speakers. And I now hand over mic to Dr. Pandey for concluding this session.
Thank you very
you,
much,
sir.
sir. Thank you very much.
Thank you, sir.
On behalf of CME Foundation of India, I thank to all faculties, especially Professor Debashish Chowdhury, Dr. Sumit Singh, Dr. Girish Kulkarni, Dr. Bhargavi Ramanujam, for your scientific update and introduction in the areas of migraine prevention and management. We hope the doctor participants today must have had the same enriching experience. Last, not the least, I would thank Mr. Deepak Naik, who's the MD of Health and You Company, and Mr. Prashant Pawar for supporting us in contributing the cause of continuing medical education. Thank you, everyone. Thank you. Have a nice day.
Thank you. Namaskar.
Would like to say anything?
Yeah, it was our pleasure to have you with us, the faculty of this program. And one point that came out very strongly, continuing medical education, both for doctors and patients, we are looking forward to associate with you to do that and to implement that. Thank you very much for giving us the opportunity to carry this program.
Namaskar.
Most welcome. Most
Namaskar.
welcome.
Thank you very much. Good night.
Thank you. Good
night,
night,
sir.
everyone.
Thank you.
Good night. Bye.